Good morning, council member. This is Marquez.
Morning, Marquez.
Okay, let me check with cable, make sure they ready.
Okay.
All right. Council member, you can start when you're ready.
Thanks, Marquez.
Okay.
Okay, good morning. I am calling this Performance Oversight Roundtable to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Tuesday, January 27th, 2026. The time is 11:31 a.m. And due to the continued inclement weather, this performance oversight hearing, or part one of this performance oversight hearing, is entirely virtual today. Today, we will discuss the performance of the Office of the Deputy Mayor for Health and Human Services, as well as the Department of Healthcare Finance for fiscal year 2025. The hearing today, again, will only be for public witnesses. We will hear from the government witnesses on Thursday, January 29th at 9:30. The Office of the Deputy Mayor for Health and Human Services supports the mayor in coordinating a comprehensive system of benefits, goods, and services across multiple agencies to ensure that children, youth, and adults with and without disabilities can live healthy, meaningful, and productive lives. DMHHS provides leadership and for planning, policy, government relations, and communication and community relations for the agencies under its cluster. DMHHS also manages two special initiatives, Age Friendly DC and the Interagency Council on Homelessness, as well as oversees the mayor's encampment cleaning and closure program. The Department of Healthcare Finance provides health care services to low-income children, adults, seniors, and persons with disabilities. With over 296,000 district residents, approximately 40% of all residents, they're receiving healthcare services through Healthcare Finance's Medicaid and Alliance programs in 2025. Healthcare Finance strives to provide these services in the most appropriate and cost-effective settings possible. The committee sent pre-hearing questions to the agencies, and they will be referenced today as well as through the government hearing on Thursday. If anyone watching would like to see those materials, they can be found online on the council's website, dccouncil.gov/hearings. I don't see any of my colleagues at the moment, but should any of them join us, we'll certainly turn to them for their opening statements. We're going to turn now to the public witnesses. All public witnesses will have 3 minutes to testify unless you're using translation services, in which case you will have 6 minutes to testify. The witnesses who requested translation services will be called first, and everyone is certainly welcome to submit longer written testimony for the record. You should be conscientious of your time, which should be easy on Zoom because there's a timer right here in the box. But we will certainly give you a nudge if your time expires to preserve sufficient amount of time for all public witnesses to speak today. There are also several hearings that are going on today as well. So we are in some ways a little time constrained. With that, I'm going to turn to the first panel. I'm going to call everyone for the translation services witness panel. Abby Goldstein, Guillermina Padilla Lujano, Angelica Gutierrez, and Norma Chavez. All right. For those of you who haven't joined us for virtual before, there will be a little box that pops up on your screen that says you'd like to ask you if you want to be promoted to being a panelist. You do need to affirmatively accept that invitation in order for us to promote you. Okay. I do see Miss Goldstein, I think. The other note for folks on Zoom, we can't promote you if we cannot read your name. So if it comes up as iPhone or something to that effect, we're not going to promote you. You do need to change the name on the bottom to a name that we can identify you by. Okay, Miss Goldstein, Abby.
Senora Goldstein, Abby?
Yes, good morning, Councilwoman Henderson and members of the Health's Performance Oversight Committee. Thank you for the opportunity to address the Council. Today, I will be sharing the testimony of a family I have the privilege of working with as a nurse home visitor with Mary Center's Nurse Family Partnership Program. Unfortunately, she's not able to join us herself today. It is in Spanish, so I appreciate the assistance of the interpreters.
Yes, the interpreter just want to ask from speakers to speak one or two sentences at a time to allow for proper and complete interpreting. Thank you.
Buenos días, miembros del Comité City Council y miembros del Consejo. Gracias por la oportunidad de testificar.
Good morning, members of the City Council and of the board. Thank you for the opportunity of allowing me to testify.
Mi nombre es Karen Guzmán y soy residente del Distrito 7, Washington, D.C., y les compartiré acerca de mi experiencia como participante en el programa Visitas al Hogar.
My name is Karen Guzman. I am a resident of Ward 7 in Washington, D.C., and I'm going to share about my experience as a participant in the program Visitas al Hogar, home visits.
En primer lugar, agradecida con todos ustedes y con los del programa Visitas al Hogar. Mi impacto a ser partícipe de este programa es ayuda bastante a madres, que en mi caso soy madre primeriza sola en este país.
First of all, I want to thank you all and to thank everybody at the Visitas al Hogar program. The impact I have experienced as a participant of this program is a, a great help to all the mothers. And in my case, uh, I am a first-time mother and I am by myself in this country.
Me ayuda bastante ya que no sabía mucho. Ellos me ayudaron en mi duda de cómo iba a ser mi proceso, cómo puedo ayudarme si tengo bajos recursos, de cómo iba a cambiar totalmente mi vida.
It has been very helpful because I didn't know much about anything. They helped me with my questions about how the process was going to be, how I can receive help if I am a low income person, and about how this was going to change my life completely.
Una ayuda grande que doy gracias a Dios por este programa. Las visitas al hogar son excelentes ya que conocen a la persona mejor la conversación. Te explican con más calma, pueden ver a tu hijo.
This program has been a great help, and it's a help that I thank God for receiving. Visitas al Hogar is excellent since they get to know the person better through the conversation. They explain to you step by step, and they are able to see your child.
Te orientan con la alimentación, los cambios, los primeros baños de tu hijo, cómo tener casi una segunda madre. Te ayudan trayendo algunas cosas para tu hijo.
They guide you regarding um, nutrition, how to change your child, the first baths of your child. It is almost as having a second mother. They help you bring in some items that are necessary for your child.
Si tienes dudas, necesitas algo, ellos ayudan realmente. Un programa que me gustaría que no termine, que ayuden más a personas que entramos en este ambiente de ser madre, ya que nos ayudan para que nuestros hijos puedan crecer en un ambiente seguro y estable.
If you have questions, if you need anything, they really help you. This is a program I would like to see continue. I would like to see them to continue helping more people who become mothers, since they are helping us in order for our children to be able to grow in a stable and safe environment.
Y para nosotras avanzar como madres.
And they also help us as mothers to keep on making progress.
Agradezco el consejo de DC y especialmente a las trabajadoras del programa por tomarse un tiempo para poder visitarnos, ayudarnos, ser comprensivas y preocuparse por nosotras como madres si nos encontramos bien con este cambio.
I want to thank the DC Council, and especially the workers that are part of this program, for taking the time to visit us, help us be understanding, and for worrying about us as mothers by asking if we are all right with this change in our lives.
Gracias y espero que familias semejantes a la mía puedan recibir este apoyo y crecer cada día más como personas. Gracias.
Thank you. And I hope to see families similar to mine being able to receive this support and to grow every day more as individuals. Thank you.
Thank you.
Gracias,
Ms. Lujano?
señora Lujano.
Hola, muy buenos días. Cristina Henderson y miembros del comité. Mi nombre es Guillermina Lujano Pineda.
Hi,
Soy
good morning.
residente.
Hi, good morning. I want to greet Council Member Christina Henderson and the other members of the committee. My name is Guillermina Lujano, Pineda Lujano. I apologize.
Soy residente de Columbia, de la zona 1. Soy madre soltera de 2 niños y trabajadora en limpieza.
I I am a resident of Ward 1 in the District of Columbia. I am a single mother of 2 children, and I am a worker for a cleaning services company.
Yo como mamá trabajadora necesito de mi salud, debido a que sin salud, ¿quién cuidaría de mis hijos? ¿Y quién va a, pues más que nada, quién limpiaría? Em, ¿Quién haría lo que yo hago si no hay salud?
As a worker, the first thing I need is health, because without health, who would care of my children and who would perform the cleaning duties that I perform?
Afortunadamente yo tuve el programa de Alianza, tuve mi seguro por más de 3 años.
Fortunately, I received my insurance through Alianza, and I was fortunate to have insurance through them for 3 years.
El año pasado me cortaron el seguro y estuve sin seguro como 6 meses. Para mí fue muy triste, muy desconsolador, me sentía perdida. Tenía muchos sentimientos encontrados porque estaba de por medio mi
La-
salud.
Last year, my insurance was suspended, so I spent about 6 months without any insurance, and I was feeling very sad, and I had mixed feelings because this is very important in regards to my health.
Gracias a las gestiones, afortunadamente el seguro me lo devolvieron a partir de este año. Me llegó una carta donde yo ya podía continuar con el seguro.
Thank you for several actions performed. I was able to get my insurance back this year.
Quiero contarles algo muy personal, que me tocó vivirlo en enero o el 8 de enero del 2025.
There's something very personal that I want to tell you about, something that I went through on January 8, 2025.
Yo tuve un accidente limpiando nieve y tuve una fractura en mano izquierda y no me resolvieron en la compañía, nadie me daba apoyo y a donde yo me estuve atendiendo fue en el seguro de la Alianza y fue mucha la ayuda.
I suffered an accident while cleaning snow, um, and I suffered a fracture on my left hand, and I didn't receive any response or any support or help from the company. And the only help I received was through Alianza.
Gracias a que tenía yo el seguro de Alianza, ellos me pudieron como canalizar con un ortopédico y pude con calma, después me resolvieron en la compañía, pero fueron como 2 meses de angustia, pero la Alianza fue la que me respaldó y estoy
Thanks
muy
to
agradecida. Perdón.
Thanks to Alianza, or through Alianza, I was referred to an orthopedist, and the company finally got on top of this issue, but it took 2 months, which were 2 months of worrying and concern. And I want to really thank Alianza for stepping up during this time.
A partir de mi experiencia, es evidente que todos los residentes deberían de recibir una atención médica porque es un derecho humano.
Through my experience, I can say that all residents should be able to receive health services because this is a human right.
Por eso pido al Consejo que tome medidas concretas para asegurar el presupuesto para que todas las personas pues puedan tener un seguro médico.
This is why I asked the council to take concrete actions and to approve a budget in order for every single person to receive health insurance.
Restablecer los límites en ingreso al 2.15% del nivel federal de pobreza.
To restore the income limits to 2.15% of the federal poverty line.
Thank you.
Revestir los servicios cubiertos antes del 1 de octubre del 2025.
To restore the services that were covered before October 1st, 2025.
Eliminar el límite de edad para personas mayores de 26 años.
And to eliminate the age limit for individuals over 26 years old.
Thank you so much.
Em,
You're about a minute over your.
Muchas gracias.
Yeah.
Eso es todo.
Thank you very
Gracias.
much. That's all. Muchas gracias y nos hemos pasado del límite de tiempo.
Gracias.
Thank you.
Ms. Gutierrez.
Señora Gutiérrez.
Sí, muy buenos días, estimados concejales. Mi nombre es
Yes.
Angélica Gutiérrez, vivo en la zona 2 los últimos 22 años.
Yes, good morning and thank you to the council members. I am Angélica Gutiérrez from Ward 2, where I have lived during the last 22 years.
En estos momentos estoy desempleada.
Right now,
Quería,
I am unemployed.
estoy aquí para a solicitar un mejoramiento del Alliance. Mi testimonio que les quiero compartir es de que mi esposo ha estado enfermo durante los 6 años. Nos ha ayudado bastante Alliance, pero hay
I'm I am here to request a betterment of the Alliance program. My husband has been sick during the last 6 years, and we've been receiving support through Alliance.
Y también quería pedirles que si había una posibilidad de mejoramiento de la Alliance en lo que es la cobertura. Mi esposo se ha hecho varios exámenes, ha estado en en su, viendo las citas continuas, pero solo le cubre lo necesario, no
I
cubre
would
lo más importante.
I would ask the council for a possibility to improve Alliance's coverage, since my husband has been in need of several tests, and he has been going to his appointments, but Alliance only cover the essential or basic appointments, not other appointments that may be also needed.
Sí, hay medicamentos que a él no le cubre, hay exámenes que le habían hecho, la verdad no le ha cubrido y ahorita estamos en espera de unas cirugías y lamentablemente pues no es suficiente para cubrirlo y me
And
gustaría que consideraran un poco de fondo más para el Alliance.
and right now there are several medicines and exams required by my husband that are not covered through Alliance. We are also awaiting the scheduling of several surgeries, and we know that the coverage is not enough for any of this. So we would like to request for the council to approve funds for Alliance and for Alliance to be able to cover these expenses.
Sí, por el del hecho, él no puede trabajar y yo estaba la cabeza del hogar, la que mantenía el hogar. Entonces, me gustaría que hubiera un poco más de cobertura para que en mi caso saliéramos beneficiados para que él podría seguir con el tratamiento que él necesita.
And actually, currently, my husband cannot work. I am the head of family right now, and we would like to request more and better coverage. So, in order for us to benefit from extended coverage, and in order to be able to cover for my husband's treatment.
Y por ese motivo, pues que yo no estoy trabajando ahorita, él no está trabajando. Tengo un hijo de 18 años que él se está haciendo cargo de los gastos y pues sí es lamentable ver un niño que debería de estar estudiando, ah, está trabajando por ayudar a sus padres, ¿no? Y
Well,
sí
and
me conmueve eso.
since neither my husband or I are working right now. We have an 18 years old son who has to take care of the family expenses for now, and it's very sad to see that a young man who should be studying has to work in order to support his family, and this is something that is deeply affecting me.
Eso es mi testimonio que quería darles y muchas gracias por escucharnos, muchas gracias por apoyarnos y
Th-
gracias. Bendiciones, que tengan buen día.
This is a testimony I wanted to render today. I want to thank you for listening to us. Thank you for supporting us. And I wish you have a great day today.
Thank you. I don't see Norma Chavez.
Gracias. No veo ahorita en la línea a Norma Chávez.
Okay. If she joins later, we will certainly turn to that. So thank you to this panel of witnesses for your testimony.
Gracias al panel de testigos por su testimonio. Si la señora Chávez se conecta más tarde, escucharemos entonces en su oportunidad de ella.
As you guys know, this is the performance hearing, not the budget hearing.
Como saben, este es la audiencia para tratar asuntos de desempeño, no cuestiones de presupuesto.
But we are awaiting to hear from the mayor's office about the $21 million in contingency funding for the Alliance program
Pero estamos esperando escuchar de la alcaldía acerca del fondo de contingencia de $21 millones que pudiera aprovecharse para financiar Alianza.
that may cover some of the things that you all talked about, but it certainly wouldn't restore the program in its entirety.
Que quizás pudiera cubrir algunos de los aspectos que ustedes acaban de mencionar, aunque no bastaría para restaurar plenamente al programa como tal.
But we thank you for your testimony today. I don't have any specific questions for this panel.
Pero les agradezco mucho por su testimonio el día de hoy, aunque no tengo ninguna pregunta específica para los panelistas.
Okay, so we're going to go to the next panel of witnesses. Again, to become a panelist, you'll need to affirmatively accept our invitation to join us. We're going to do panels of 7 just to kind of see who's here and kind of go from there. So Andrew Patterson, Dr. Kate Sugarman, Benjamin Brooks, Elizabeth Falcon, Kate Coventry, Jacqueline Bowens, and Allison Miles Lee. Give it a minute as folks join us. Again, there'll be a box that pops up that says, would you like to become a panelist? And you have to hit that button in order to join us. Okay, see a good group here. So I see Mr. Patterson. So why don't we go ahead and get started with you?
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Andrew Patterson. I'm a senior counsel with Legal Aid DC. Thank you for the opportunity to testify at this oversight hearing. This has been a year of difficulty and transition for many who rely on the district's safety net programs. My testimony today is to encourage not only continued policy oversight, but the policy changes that are necessary to protect the district's most vulnerable residents. Many of the mayor's most devastating cuts to the Alliance program went into effect on October 1st, 2025, resulting in thousands of district residents losing their only access to health insurance. At the changes to the district's Alliance and Medicaid programs roundtable in December 2025, this committee heard from over 60 public witnesses and advocates who testified about the profound impact the cuts to the Alliance program have had on the district's residents. The council must now take action if the district still wishes to be a leader in providing access to health insurance for all of its residents. First, we urge the council to ensure that DHCF and the Alliance fully implement, without any further delay, the restoration of pre-October 1st, 2025 Alliance Health Services that were approved through the contingency list on December 24th, 2025. Restoring these services, even temporarily, was a significant and positive development in an otherwise difficult year for thousands of district residents who have no alternative affordable coverage and rely on the Alliance program. Second, we urge the council to eliminate further reductions to the Alliance program that are scheduled to take place in October of this year, and to reverse the cuts that have already gone into effect. Specifically, the council should restore pre-FY26 income eligibility to the Alliance program, remove the age cap, and fully restore services to the pre-October 1st covered services for Alliance and Immigrants Children's Program. This is necessary to prevent even deeper erosion to the healthcare safety net for an already vulnerable population. In addition to the Alliance cuts, thousands of DC residents who previously had Medicaid were transitioned to a new Healthy DC program on January 1st. As with any change of this scale, there will certainly be instances of enrollees being improperly transitioned from Medicaid or improperly denied access to Healthy DC coverage. The most recent income information available to DHCF and DHS is what was used to determine who would lose their Medicaid. In many cases, that income information is likely outdated. DHCF and HBX have indicated they are willing to work with beneficiaries and their representatives to correct errors. And that level of interagency cooperation will be crucial, as many beneficiaries may not be aware of the changes until they are denied access to a Medicaid-covered service due to their switch. So we urge DHCF and HBX to address those mistaken terminations in a timely and comprehensive way, including providing appropriate language access services as needed. I just want to make one final point about raising revenue. Both of these changes have happened during a budget season in which the mayor and the council refused to implement any policies to raise revenue. We often heard that difficult choices had to be made, but there is no reason why all of those difficult choices had to adversely affect some of the city's lowest income and most vulnerable residents. We urge the council to consider policies to raise revenue, which I detail in my written testimony. And I also have some points about home health aid and PCA services that I will submit for the record with my written testimony. Thank you for the opportunity to testify.
Thank you. Dr. Sugarman.
Yes, good morning. I am Dr. Kate Sugarman. I am a family doctor at Unity Healthcare. My current clinic is in Ward 1, and I know from real time the benefits that were previously covered by DC Healthcare Alliance, how it allowed my patients to live healthy, and now I'm seeing the devastation that the cuts are already having on my patient. So the many examples I have are, in particular, many of my patients with diabetes that were previously under the previous alliance getting the medications that they needed and getting the specialty care that they needed because of the devastation that diabetes can wreak on the body. So, what I see now is patients literally losing their vision because they can't get the diabetic eye care that they need. So patients that were able to work, be independent, take care of themselves and their family, they're no longer able to access due to the cuts to the DC Healthcare Alliance. I know that during the roundtable in December, Director Turnage said that DHCF would convene an advisory council for Alliance. When will that first meeting be? And also, we strongly urge that DC Alliance Healthcare be restored with these changes, that the income limit should be returned to 215% of the federal poverty level, that the services covered by Alliance before October 1st, 2025 should be restored, that the age cap for adults 26 and over be removed. According to previously estimated numbers from the CFO, the total cost would have been $43 million. I just urge you on behalf of my patients to restore DC Alliance how it was so my patients can live dignified, healthy, and independent lives. Thank you.
Thank you. Mr. Brooks. Oh, hang on one second. Ashley, if we could, somebody restart the clock.
Sadly,
Hold on, Benjamin. I'm waiting on my team to.
no worries.
Okay. It looks like we are having some issues, so I'm gonna have to do it old school, which is fine. This
Great.
technology is technology. So let me set a timer. And we'll go from there.
Correct myself as well. All right.
All right, when you're ready.
Thank you, Chair Henderson and members of the committee who will watch this recording. My name is Benjamin Brooks. I'm the Interim Director of Policy for the Institute for Health Research and Policy at Whitman Walker. We're very glad to submit testimony on the oversight of the Department of Healthcare Finance and its mission to support access to comprehensive, cost-effective, and quality healthcare services for all of the residents of the District of Columbia. Today's testimony primarily concerns the implementation of the Healthcare Alliance program. It's helpful to mention, and I'm glad to share that we have over 50 years of experience in serving the greater Washington, D.C. metropolitan area, including large numbers of patients with complex healthcare needs. And of course, it means we have considerable expertise in supporting healthcare access. Most notably, our Legal Services Department is the nation's oldest and largest medical legal partnership with over 4 decades of leadership in public benefits law. Our Public Benefits and Insurance Navigation team, lovingly called PBIN, serves under the direction of our senior legal services managers and has played a key role in health insurance enrollment in the District of Columbia. We help all of our patients and DC area residents with health insurance eligibility enrollment, including the Healthcare Alliance program, among others. Our healthcare navigation services are available in Spanish, English, and Amharic. We appreciate the Council for agreeing to add the Healthcare Alliance benefits to the budgeted contingency list. It has been over a month now since the Chief Financial Officer certified that contingency list, and we need to see continued and increased partnership with DHCF to ensure that the program recipients are able to access their full benefits. These benefits are available because of the intense investment in advocacy and education conducted by Alliance members and their allies who understand the foundational role of healthcare insurance in promoting access to this social and economic life in the District of Columbia that promotes all of our well-being. In particular, we believe the Department of Healthcare Finance needs support in implementing a sensible approach to medication access. They've implemented medication access barriers like generic only and utilization requirements that are administratively burdensome and clinically inappropriate. The formulary restrictions that they've implemented cause barriers for people living with HIV, people living with diabetes, and people living with heart disease that inappropriately push patients off of medications, increase out-of-pocket costs, and take extensive time for providers to navigate. The restrictions to the formulators are not clear for providers or beneficiaries, and based on the Council's decision to fund the Healthcare Alliance program back to the pre-October 1st, 2025 benefit levels, we believe that DHCF should immediately eliminate the new formulary restrictions and revert back to the previous formulary. This change is one of the most administratively feasible of the changes, and DHCF can implement them with immediate effect, increasing access to life-saving medications and reducing the administrative burden on providers and families. We know as well that dental coverage is critical, and oral health is literally a gateway to preventive care. And so I know that I'm at time, but I want to make sure that we emphasize that these benefits should be added back as well. Thank you so much for your time. Thank
you. Okay, the timer did go off, but my phone is on silent, so it's vibrating on my watch instead. Gonna work through that. All right.
I set my own as well.
No, but you did a great job. Thank you, Mr. Brooks. Okay, Elizabeth.
Good afternoon or good morning, afternoon, Chairperson Henderson. Thank you for the opportunity to testify today. My name is Elizabeth Falcon. I'm the Executive Director of DC Jobs with Justice. Since this spring, DC Jobs with Justice has acted as an anchor organization for the Keep DC Healthy campaign, joined by 25 other organizations. Since the start of FY26, the Department of Healthcare Finance has overseen a rushed and chaotic rollback of benefits for the DC Healthcare Alliance patients, as over 2,000 lost all of their coverage and all 26,000 plus saw a reduction of benefits. Since October 1st, patients and providers have been confused regarding basic care provisions such as which medications are covered, when can patients with lapsed enrollment still reapply, what programs best serve patients who are pregnant, and if life-saving treatments will be provided. The outcome of this has been a community of immigrant patients who've been cut off from care, ranging from lost dental services, primary care, cancer treatments, and dialysis. At the same time, these communities have been under intense threats from the federal government, including multiple violent attacks at bilingual public schools, which sustain fear that keeps families away from needed public services and community support. Additionally, the council mandated that the Department of Healthcare Finance restore benefits to current Alliance patients as part of the contingency revenue list passed in the FY26 budget. These funds were duly certified by the Chief Financial Officer and is the responsibility of the agency to restore the funding. In the months since these funds were certified, Department of Healthcare Finance has made no public statements to patients or providers that indicate they intend to follow the law and restore benefits. The $21 million restored by the council represents thousands of appointments that patients could have access to care they need, like new eye prescriptions and dental clearings. The Alliance has provided critical care, and I've had the honor of hearing many patient stories. Workers suffering repetitive stress injuries can continue working, diabetes patients thriving with adequate care. Instead, now mothers are concerned about what the loss of care will mean for their children. Tens of thousands of DC residents' lives have been made better because of the care they can access through the Alliance. The council now has the power to restore funding to these families now and in the long term. The inclusion of the funds on the contingency list was a critical first step, and we look forward to more this year. We ask you to meet the needs of Alliance patients. On Thursday, when Deputy Mayor Turnage is here, ensure that he answers critical questions such as when will the programs restored through the contingency list actually be available to patients, and when will patients and providers be informed of these changes? And when will they convene the advisory council, which he promised at the roundtable late last year? If he fails to provide answers, please take additional steps to ensure patients can access the care they need and restore the Alliance program so that patients have the same level of care in the coming year as they did in September. Thank you for the opportunity to testify.
Thank you. Okay, so there does appear to be a timer back. I don't know, for the folks if you are a panelist, you can see it. It's on the top bar. It's small, but it'll be on the right-hand side when the timer starts again. And then, Ms. Falcon, was that you with the sound?
Probably. I have my daughter watching TV behind me.
Okay, I was like, that was definitely giving Disney, like Walt Disney, we're here. But nonetheless, we're going to try our best on that front. So, Kate, you are next.
Chairperson Henderson and members of the committee, thank you for the opportunity to testify today. My name is Kate Coventry. I'm the Director of Legislative Strategy at DCFPI, a nonprofit organization that shapes racially just budget, tax, and policy decisions by serving Black and Brown communities in our work. As you've already heard, more than 2,200 residents have already lost Alliance coverage with few and inadequate alternatives. Newly ineligible immigrant residents will struggle to pay for health care, may avoid or delay needed care, and even die from diseases that could have been successfully treated if the individual had received timely care. This program change comes as the federal government escalates deportations and targets immigrants for other benefit cuts. Congress has recently excluded more lawfully present immigrants from Medicaid, and federal agents are rounding up immigrants, including those with legal statuses. And lawmakers have made other harmful changes, including eliminating the Alliance for adults over age 20 in the future. These cuts will primarily hurt Hispanic and Black residents, and are part of a current current federal and local changes that are part of a long racist history of restrictions on immigrant access to health care. I'm going to echo a few of the people who testified in front of me to ask about if you could ask the agency where they are in implementing the contingent revenue provision and to re-expand benefits, that would be great. We also want to highlight some of the other harmful causes that these cuts will create. It'll put additional pressure on federally qualified health centers. You'll hear more from them later today. Increased reliance on costly emergency room visits, increased medical debt for residents with low income, and loss of coverage for pregnant people just 2 months after delivery. The council should create an advisory council to look at these negative effects, identify savings, and delay further cuts. The Deputy Mayor of Health and Human Services, Wayne Turnage, has argued that Alliance costs are increasing too fast, but for reasons that are not entirely clear to agency leaders. He testified in the summer of 2025 that the budget would have to more than double since 2011, from an inflation-adjusted $74 million to a projected $247 million in 2026 if lawmakers made no changes, and that the per enrollee annual cost more than doubled from $2,576 in 2011 to $6,671 in FY26. However, the projection for FY26 is far higher than the approved FY 2025 budget for the Alliance and the Immigrant Children Program together, which totals about 150 million. The agency has not made the assumptions behind this increase public. Just want to flag that increased Alliance costs are not outside the norm. Health costs typically grow faster than inflation, have sharply increased in the US over the past few decades. Rather than just cutting people off, the agency should form an advisory council to look at these issues and identify potential savings. Thank you for the opportunity to testify.
Thank you. Jackie Bonds.
Good afternoon, Chairperson Henderson and members of the committee. I want to thank you for this opportunity to present testimony at the Department of Healthcare Finance's 2026 Performance Oversight Hearing. On behalf of DCHA and our members, I want to begin by thanking the department for their leadership and steadfast commitment to ensuring the healthcare needs of nearly 300,000 district residents are met. Under the direction of Deputy Mayor Turnage and Medicaid Director Melissa Bird, the department has maintained a strong relationship with our hospitals, remaining accessible and responsive to operational questions related to policy implementation and program administration. And this collaborative approach has really supported the stability and coordination across our hospitals, which has been vitally important to an evolving healthcare landscape. As our members and others across the healthcare system continue to adjust to the Medicaid and Alliance changes, close collaboration with the department is critical to assess the impact of these changes on our hospitals and the industry. DCHA will start collecting financial data from our members now that we are 1 quarter into the Alliance program changes, and will hopefully be able to provide insight during the budget testimony. In addition to Alliance changes, we're carefully evaluating the Medicaid Healthy DC plan transition with particular focus on rate setting for future years for that population, since the costs tied to those beneficiaries will no longer be factored into Medicaid rate setting, which is what reimbursement is based on for this population. Our hospitals are also working with Healthcare Finance to understand the impacts of the new outpatient Medicaid rate methodology that went into effect on October 1st. Hospitals believe that this methodology change is resulting in a 15% reduction in outpatient rates, or about $46 million overall. We recognize that ongoing conversations with the department will be essential to understanding that impact. We have also continued to work closely with the department on the hospital-directed payment program, which, as you know, was approved by CMS in September. And this achievement could not be possible without the support of Angelique Martin, Joseph Brennan, Darren Schaefer, and Eugene Sims. Their transparency and responsiveness to our feedback throughout this process has been essential to this particular outcome. Our goal is to begin developing a framework with stakeholders this spring to work on the community reinvestments and to ensure that these are aligned with the community health needs. As the district continues to face fiscal pressures and growing healthcare needs, we appreciate the department's collaborative approach with hospitals and look forward to our continued collaboration with them. Thank you for the opportunity to testify, and I'm happy to answer any questions you may have.
Thank you. Ms. Mousley.
Thank you. Good afternoon, Chairperson Henderson. My name is Allison Miles-Lee. I'm a managing attorney at Bread for the City. As you know, Bread for the City is also a federally qualified health center, and thank you for your recent visit to our Northwest Clinic. I'm here to urge the council to restore Alliance Health Insurance benefits to immigrants. In my 17 years at Bread for the City, I have often been proud that DC does the right thing for its immigrant residents, even when the federal government does not. In the first Trump administration, the federal government tried to scare immigrants away from using public benefits by instilling public charge fears. In DC, though, when immigrants were among the hardest hit groups by COVID, DC maintained Alliance Health Insurance so they could access critical health care. In fact, it was during this time that DC increased the renewal period for Alliance from 6 months to 1 year and fully removed the face-to-face interview requirement. Both of these changes made it easier for immigrants to access and maintain insurance. Alliance is a critical safety net for immigrants in the city, and because of recent changes to health insurance at the federal level, it has become an even more essential program. People think of Alliance as insurance for undocumented immigrants, but now certain documented immigrants like asylees and refugees are going to become ineligible for federal health care that they currently receive. Instead of falling into the safety net of Alliance, which they would have been able to do, now that net has been ripped out from under them and they'll be left with no insurance options at all. One of our medical patients is an 80-year-old asylee. He currently receives Medicaid and does not qualify for Alliance because the requirement for Alliance is ineligibility for Medicaid. Starting this October, thanks to the big, beautiful bill, refugees and asylees will no longer qualify for Medicaid, and his Medicaid will be terminated. He's already ineligible for Medicare because the federal government made refugees and asylees ineligible for that last year, and he'll become ineligible for subsidies in the marketplace starting in 2027. Alliance should be available to our patient as a fallback once all his other insurance options push him out. But because of the DC Council's moratorium on new Alliance applications for adults over 26, he will be shut out of Alliance. Another Bread for the City patient is married to a U.S. citizen and has had a green card for 2 years. In 2025, she and her husband were both working and she received Alliance. Last October, she was terminated from Alliance because her family's dual income put her over the new income limit. Since that time, her husband lost his job. Our patient cannot reapply for Alliance, even though she would now qualify with her lower income due to the moratorium on new applications. We considered helping her enroll in a basic health plan, which is an option since she's lawfully present, but she does not qualify for that because her income is too low. Bread for the City will continue to see our patients, but we are a primary care facility, not a hospital. We do not have high-tech equipment that's necessary to screen and keep patients healthy, and we are not a free pharmacy. DC used to believe that everyone deserved health insurance, but now, rather than being here to catch our neighbors who are knocked down by the federal government, as we have in the past, we are cutting their existing benefits. Thank you very much.
Thank you. Thank you to this panel of witnesses for your continued engagement on issues, particularly around healthcare finance. I want to ask a couple of questions. Brooks, I wanted to start with you if you're still here.
I'm here. Thank you, Council. Thank you, Chair.
So here you talked a little bit about formulary limits, generic brand. In the past, healthcare finance has said that they can make exceptions and review all cases that require non-generics. Is Whitman Walker finding that this is not occurring?
That's my understanding is that we're finding that it is occurring, but it's just more administratively burdensome than being able to immediately dispense the medications the patients need because doctors are prescribing them. Dr. Sugarman has direct experience with this issue and may be better equipped to answer your specific question.
Dr. Sugarman?
Yes. So in real time, we're having significant barriers which are causing adverse patient outcomes. So under the previous Alliance formulary before October 2025, the prominent examples mostly are for diabetics with their injectable medications. Before the October 1st reductions, patients were getting the medicines they needed for their diabetes, and also blood thinners for patients with strokes and blood clotting disorders and heart disease needed certain blood thinners. And with the change, they are technically, able to get them under Alliance, but the burdens with the prior authorizations are causing many adverse outcomes for the patients who, critically need these medicines. So we really want the medication allowances to go back to the pre-October 1st way. There was a formulary and the formulary worked. And now the burdens are, technically they can get it, but the burdens are really causing adverse patient outcomes.
Thank you. Ms. Bowens, I wanted to ask a question with regard to use of emergency Medicaid in terms of your hospital members. We sent pre-hearing questions to Department of Healthcare Finance, and we noted that the use of emergency Medicaid has gone up. I'm curious if that is something that your members have talked about in terms, especially in this last year, that we're seeing a lot more patients needing to use that option.
Chairperson Henderson, can I get back to you with some details on and answering that question? I'm not prepared right now to give you a response, but I will get you that answer shortly.
Okay, thank you. I know we discussed that in terms of the medical debt bill. And so we just that was a note for us.
I've heard a few things, but I want to make sure I give you the right answer. So we'll do a quick survey and I'll get that to you before the end of the week.
Okay, great. Thank you. I also wanted to ask, and I'm not sure, I guess would be the case for any of the hospitals, but also for any of the folks who are working at clinics. if you could say a little bit in terms of how the transition is going in terms of Healthy DC. Are we running into issues in terms of enrollment? The committee hasn't received any sort of widespread complaints about the transition, but you all would be on the front lines of sort of processing that information. And so I'm curious what the experience has been thus far. Allison?
Sorry. I was just going to say that I think the biggest issue really is about communication. And so we're going to be working to really elevate communication and people understanding that what's different, particularly in terms of their eligibility and the benefits and how to access services. So we're going to be working with the department and others to really elevate that understanding and awareness. So that's the one thing I would mention, I believe is a big issue is folks really understanding that they've transitioned and what the differences are in terms of coverage.
Okay. One of the communications that we already sent out, we heard an issue from the DC HealthLink was providers who were still checking the database for Medicaid as opposed to the new database to sort of
both ways.
Yeah. Allison, I see you sort of shaking your head.
Yeah, so we haven't seen a lot of issues yet, just because I think people don't know that they've been transferred or don't understand what that means. So Bread for the City and Legal Aid tried to do a clinic last week at our Southeast location. And we had done some outreach to get people, anyone that had questions about the change or that had experienced a problem with their health insurance to come talk to us. And we got 3 people that came in. And we actually had a ton of people coming into Bread for the City for food that day because it was right before the storm. And we were kind of surveying people in the lobby, going up to 100 people, asking if they had seen a change, and nobody had. And so I think of that population, right? Like there's got to be people that were switched over to BHP that just didn't know it, or that maybe got terminated from Medicaid and not put in BHP. It was just too large of a sample size for there not to have been anyone impacted. So I just think it's kind of early days.
Okay. Mr. Brooks, did you have anything you wanted to add there?
Thank you. I'm actually going to follow up with our PBIN team and provide that information in our written testimony.
Okay, that sounds good. I'm not asking any sort of specific questions about alliances. I think I've heard from all of you in December on this already. The unfortunate thing in terms of this storm is that this morning there was supposed to be a mayor council breakfast, and we were supposed to be discussing the alliance and the contingency fund. Unfortunately, that breakfast had to be rescheduled. So I don't have any updated information in terms of what's going to happen there. But hopefully we will, I think that's being rescheduled soon, so we'll be able to get some further information there. But thank you all for your testimony. We're going to go to the next panel of witnesses.
Thank you.
Okay. Maggie Snow, Catherine Landfield, Eric Angel, Rose Maroney, Ruth Pollard, Mark Lavoda, and Kristen Ewing. I'm just giving it just a minute for folks to switch out. Okay. All right. I see Maggie. So Maggie, when you're ready.
Good afternoon, Chairperson Henderson and committee members. Thank you for the opportunity to speak today. My name is Maggie Snow. I'm the Anti-Hunger Program Associate overseeing our SNAP work at DC Hunger Solutions. I'm also a DC resident. In my role, I provide direct support to residents experiencing hunger and use their feedback to inform my advocacy efforts. In FY25, our organization pre-screened over 1,300 residents and helped over 700 apply for SNAP. We thank the Department of Healthcare Finance for supporting District Direct, which residents rely on to communicate with DHS. I want to specifically thank DHCF contractors Tara, Perna, Bargov, and Guarov. Their attention to detail and responsiveness helps so many of our clients access benefits. We also want to thank DHCF for adding a banner to District Direct that lets clients know they may be eligible for WIC and directs them to make an appointment. As we've shared in previous testimony, language access continues to be a major issue. We recently learned that DHCF is one of the lowest scoring agencies in terms of language access based on an annual study conducted by the Equal Rights Center. This is a major concern, especially right now as clients are receiving notices about changes to SNAP work requirements and alliance coverage. Without proper translation, clients cannot access these notices and respond appropriately. Today, I'll recommend 4 ways to make District Direct more accessible, specifically to SNAP applicants, but all clients. Automatic generation of person reference numbers, continued improvements to the immigration portion of SNAP recertification, addition of an out-of-pocket medical expense question, and changes to make the mobile app mirror the web version. We've shared with the DHCF TAC team that it can be hard for clients who don't have a social to connect their District Direct account. Per the TAC team, accounts should automatically connect, but this doesn't automatically happen. Clients currently have to call the ESA call center or wait for mailed letters to receive their PRN and connect their account. Ensuring accounts automatically connect will help both clients and DHS to respond more quickly to applications. Second, we urge the TAC team to continue working on a fix that, to a glitch that affects many mixed status families when they complete their SNAP recert. Families who have not had a change in immigration status are often unable to move past this page without updating their information. While we appreciate the quick response when addressing individual case issues, we need a long-term solution to prevent the glitch from happening. Third, we request that a question be added to ask explicitly about out-of-pocket medical expenses on the SNAP application. And finally, we ask the department to adjust headings and menu options on the mobile app to make the options match the web version. This will make it easier for both DHS call center reps and community advocates to guide clients through using the mobile app. These recommendations are directly informed by my daily interactions with clients who rely on District Direct for benefits processing. Thank you for the opportunity to offer testimony.
Thank you. Catherine?
Hi, good afternoon, and thank you for the opportunity to testify, Chair Henderson and members of the committee. My name is Catherine Lamfield, and I'm a longtime DC social worker, currently serving as the Senior Advocacy Strategist at Fair Budget Coalition. Fair Budget is deeply concerned about DHCF's administration of the Healthcare Alliance this past year. The Committee on Health should ensure that the Alliance again functions as an essential source of full care for its participants as it did 1 year ago. The program changes and funding cuts that DHCF rolled out for FY26 deeply impact community members, with negative ripples outward through the healthcare ecosystem and the DC economy overall, as you are hearing and will hear from other testimonies. Given that the district has among the most extreme racial disparities in health outcomes in the country, it is essential for DC to ensure quality health care for Black and Brown working class and poor residents, including our immigrant neighbors. DHCF's administration of the Alliance moves us backward in the struggle to close these racial inequities. We are particularly concerned about reports from providers and participants that Alliance services still have not been restored with contingency list funding that the CFO certified in December. Healthcare cannot be slow-walked. I have directly observed in over 20 years as a social worker that the harm of inadequate healthcare is ongoing, cumulative, and radiates throughout families and communities. We urge your community to provide strong oversight, holding DHCF's proverbial feet to the fire for transparency and accountability. When will the funding be implemented to restore services, and why hasn't it been? When will the deputy mayor hold the first advisory council meeting? What is happening with funding and access to behavioral health care services through the Department of Behavioral Health? Behavioral health is also essential to community well-being, and we have fought hard for parity and coverage and urge policymakers not to let it slip away. Lastly, please legislate to restore the programming and eligibility levels that the Healthcare Alliance had in FY25. The narrative that we cannot afford it is misguided and false. It is unconscionable that in a year when almost 1.5 billion in direct and indirect public subsidies went to billionaire sports team owners, our most vulnerable community members faced deep cuts not only to their health care, but other safety net programs as well. DC must reallocate resources to invest in these communities now more than ever as the federal government literally and metaphorically attacks immigrants and poor people. We strongly echo the call to consider new revenue, which I include more about in my written testimony. I look forward to answering any questions. Thank you very much.
Thank you. Eric?
Good afternoon. My name is Eric Angel, the new-ish Executive Director of DC Greens, where we work to advance health equity by building a just and resilient food system. Today, I want to hone in on just one issue. I'm testifying in strong support of DCHF's with respect to the way it funds and supports the Produce RX program, which is administered by DC Greens. DCHF views this as a true partnership and has handled the grant with professionalism, attention to detail, and efficiency. Given the successful oversight of the program, we would request that this be converted into a multi-year grant in the years to come to enhance the efficacy and efficiency of this program. Our produce prescription program is part of the National Food is Medicine movement, a movement I know you know a great deal about, which recognizes that access to healthy, nutritious food is key to preventing and treating diet-related illnesses while reducing healthcare costs and stimulating the economy. Our program is the oldest and largest such program in DC. It's really quite amazing. The way it works is that doctors at nonprofit clinics quite literally prescribe fresh fruit and vegetables to qualifying Medicaid and Healthcare Alliance patients. The qualifications are simple. Person needs a diagnosis of obesity, hypertension, prediabetes, or diabetes, and have the capacity to visit participating grocery stores. We then send a debit card loaded with $80 to $120 to the participant households on a monthly basis for a year. They can be used for fresh fruit or vegetables at local grocery stores and Arcadia mobile markets. At its peak, the program distributes more than $1 million annually to 1,000 or so households, and we could not have done this without the DC government appropriation or the partnership with DCHF. These interventions are critical to DC's health and well-being. We know many of the statistics, but they're still shocking to hear. For these purposes, I'll just focus on one: obesity, which contributes to the severity of most chronic diseases, is widespread in DC. Overall, according to DC's own statistics, 55% of adults in DC are overweight. In Ward 7 and 8, the rate is 72%. More DC residents die each year from complications of obesity than from AIDS, cancer, and homicide combined. We have some powerful testimonials from participants in our written testimony, but in the interest of time, let me just say that at DC Greens, we envision a day where access to healthy, nutritious fields is part of the healthcare system. And we know that DCHF and the council share that aspiration. We've been working with the district to receive a Section 1115 waiver from the federal government to allow produce prescriptions to be funded through Medicaid. And I repeat that given the successful stewardship of the program, we respectfully request that this be converted into a multi-year grant in years to come. Thank you so much.
Thank you. Rose? Rose Maroney?
Hi, council member. This is Maggie from DC Hunger Solutions. Rose will be submitting written testimony instead of providing it on live today.
Okay, great. Thank you. Ms. Pollard.
Good afternoon, Chairperson Henderson and the Committee on Health. My name is Ruth Pollard, President and CEO of the DC Primary Care Association and Executive Director of the DC Connected Care Network. Together, the DCPCA and the DCCCN advance a unified strategy that strengthens DC community health centers, expands access to affordable, high-quality care, and improves health outcomes for the residents we serve. Thank you for the opportunity to provide testimony regarding the Office of the Deputy Mayor of Health and Human Services and the Department of Healthcare Finance. The Office of the Deputy Mayor for Health and Human Services plays a critical role in aligning the administration's efforts to achieve health equity in the District of Columbia. Our written testimony includes recommendations regarding value-based contracting, MCO oversight, Medicaid work requirements, and more. Today, though, I will focus on our top priority, protecting patients. DHCF works to address challenges in the Healthcare Alliance program that led to restrictions in eligibility and services in fiscal year 26. DCPCA and DC Connected Care Network stand ready as DHCF's strongest partner to improve health outcomes and contain costs for the residents we collectively serve. DCPCA and the 7 community health centers in the DC Connected Care Network are developing a shared model of comprehensive, affordable, team-based primary care to be implemented within a value-based framework. This model is designed to protect patients and stabilize their access to care especially those most at risk of coverage loss. By strengthening community health center-led management, expanding services where needed, and implementing an advanced primary care approach that pairs patient-centered care with enhanced access, better use of data, and realigned payment models, we can support a more sustainable and effective alliance program. Before I close, I would like to thank you, the Committee on Health, and the 7 council co-sponsors for introducing B 260523, Streamlining Medicaid Credentialing Amendment Act of 2025. We urge the council to pass this bill and DHCF to move quickly to implement its intended improvements. In closing, DCPCA and our community health centers are deeply grateful for Deputy Mayor and DHCF Director Wayne Turnage and his dedicated team. We believe in our shared ability to build a health system where every DC resident, regardless of neighborhood or their circumstance, access to high quality, affordable primary and preventive care. And we stand ready to work alongside DC Council Committee on Health to make that vision reality. Thank you so much.
Thank you. Mark?
Hello, Chairperson Henderson and members of the council. Thank you for the opportunity to testify today. My name is Mark Laboda. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole-person care for district residents with mental illnesses, substance use disorders, or both, including the 35,000 district residents that our 35-member organizations serve annually. The Department of Healthcare Finance was called upon to make difficult choices in 2025, the impacts of which have not yet been fully seen. Federal changes created significant distractions from DHCF's work to advance its own program priorities. My testimony today will focus on DC Medicaid and DC Healthcare Alliance program eligibility changes and DHCF taking additional responsibility for behavioral health services previously carried out by the Department of Behavioral Health. DC Medicaid and DC Healthcare Alliance eligibility changes have tested how far the district government can shrink the district's medical safety net. A line has been drawn at 138% of federal poverty for adults. This already is too far for people with the most severe forms of mental illness, as the Department of Behavioral Health has been forced to concede with no new local dollar subsidies for assertive community treatment for people with reduced coverage. The transition back to fee-for-service for the Alliance also has not been smooth, particularly for people who have a history of favorable treatment outcomes when using brand name medications without equally efficacious generic substitutes. A generic first policy balances treatment preferences with cost containment. A generic-only policy unnecessarily drifts toward inadequate coverage. Over 2025, the Department of Healthcare Finance reclaimed responsibility for several roles that had been delegated to the Department of Behavioral Health. New focus to address behavioral health in DHCF's program integrity team was overdue, and more still needs to be done. DHCF's contractor, CoMagin, became responsible for authorization reviews for adult crisis beds, with a fairly reasonable clinical approach, but significant operational challenges that have only been partially resolved. Reinstatement of authorization reviews for community support services is now also in the hands of CoMagin. DBH and DHCF both fell short by not putting community support authorization reviews back in place after the managed care carve-in of behavioral health services did not move forward. Even after agreeing that action was needed in April of 2025, authorizations were not active until November, and will still remain available to multiple organizations for the same service for the same consumer's care until at least early March of 2026, nearly a full year later. Allowing multiple provider authorizations leaves in place a mechanism for exhaustion of available billing units while consumer needs persist. It's good to see DHCF retaking responsibility for roles that DBH is no longer staffed to carry out, but DHCF needs to approach its role in management of payment functions for the DBH provider network with much greater urgency. Thank you for the opportunity to testify today. Look forward to answering any questions you may have.
Thank you. Kristen?
Good afternoon, Chair Henderson and staff. My name is Kristen Ewing, and I am Policy Counsel at DC Appleseed, where I lead our long-term care project and chair the DC Coalition on Long-Term Care's Workforce Committee. My testimony will focus on the need for strategic coordination and planning to address the long-term care crisis. DC's population is aging rapidly, and the demand for home and community-based services, assisted living, and nursing facility care will continue to grow for decades. At the same time, providers across the continuum report severe workforce shortages driven by low wages, high turnover, and training barriers. These challenges are already affecting residents and families through service waitlists, unmet needs, and instability in care. This is not just a service gap, it is a system-wide and fiscal risk. When residents cannot access reliable home and community-based care, they experience preventable hospitalizations and premature nursing facility placement, driving higher Medicaid costs and straining hospitals, emergency rooms, and families. The district also has legal obligations to support residents in the most integrated setting possible, which makes coordinated long-term care planning essential. We deeply appreciate the committee's creation and funding of the Long-Term Care Strategic Coordinator role at DMHHS in the recent budget. We understand that DMHHS plans to incorporate this role into the Age-Friendly DC Coordinator position, a position that has been vacant but we understand should be filled soon. While we believe the long-term care systems coordination and age-friendly initiatives are distinct areas that ultimately warrant separate, dedicated roles, we view this as an important and positive first step towards building full-time coordination capacity. We urge DMHHS to stand up this expanded position as quickly as possible and ensure it has the authority, staffing, and leadership support needed to drive cross-agency and cross-sector coordination. Delays will only deepen existing gaps in planning and implementation. This role must be empowered to convene agencies and engage providers, consumers, families, and advocates. It is crucial the coordinator lead the development of a district-wide long-term care strategic plan with measurable goals and accountability. We recommend the council require annual reporting on coordination efforts, workforce initiatives, and the implementation of the strategic plan to ensure transparency and sustained progress. The coordinator role has the potential to be transformative for older adults, people with disabilities, and the long-term care workforce. DC Appleseed and the DC Coalition on Long-Term Care stand ready to partner with the council, DMHHS, and the new coordinator to advance this work. Thank you for your leadership and the opportunity to testify. I have submitted written testimony and I'm happy to answer any questions.
Thank you. Thank you to this panel of witnesses. Kristen, I want to start with you in terms of the long-term care strategy. So when we created or directed DMHHS to use one of their positions specifically for long-term care as opposed to just age-friendly DC, it was with the goal in mind of doing the very thing that you talked about. Because when I think about some of the pieces in terms of long-term care, this is a multi-agency approach that includes a variety of things. Frankly, I mean, even last week when we had the hearing on St. Elizabeth's Hospital, you know, they have patients at St. Elizabeth's Hospital that probably shouldn't be there, but there's nowhere to discharge them to in terms of memory care or a nursing home that will accept them. What are your thoughts on some of this?
So one of the biggest issues that we think we need to address is bringing every agency together. This is across, DOES, OSSI. For training providers, we have Department of Healthcare Finance, we have DMHHS, we have DC Health, we have the Board of Nursing. They all play a role. And I think they're all working in some ways to address this issue, but they're not working together. And the places that we have seen that are really excelling in their long-term care are places that have created a strategic plan. For example, New Jersey just released a strategic plan. I think they worked with 9 or 10 different agencies within New Jersey to release that. But I think the system-wide impacts that you were mentioning with St. Elizabeth is one of the biggest issues we're going to see. And that is if you have someone in a hospital who cannot be discharged to a nursing home because the nursing home is full because someone there cannot be discharged to home care, then that takes up a bed. And then you have someone waiting in the emergency room. And then you have people waiting in the waiting room of the emergency room. So it is not just about long-term care. It is about the whole system. And if we do not address it, we are going to see not only system-wide impacts, but higher costs, but also just poor health outcomes.
Yeah, that I think that's certainly a concern I have. I mean, we have a population that is aging for better or worse. And I think we need a system and a strategy in place to address that. Thank you. Thank you for being here. Ms. Pollard, I want to ask you something that I asked the panel earlier with regard to the transition to Healthy DC and some of the feedback from your member groups, because as primary care, you guys are at the front lines on some of this.
Sure, I'm happy to answer that question. What we're hearing from the community health centers is that they would like the BHP MCOs to configure searches on MCO portals to allow name and birth date and not just subscriber number, because the beneficiaries don't know their numbers or they've not received a card yet. So that's really key. That's what we're hearing most from our community health centers.
Okay, that's super helpful in terms of feedback. And you're correct. If somebody were to ask me for my subscriber number, I'd be
I have no idea.
I'll pull out the card and we'll go hope for
Exactly.
the best, but that's definitely not something I would sort of know up front. Okay, so thank you. Thank you for that. Mr. Angel, Produce RX. Now, as far as I can remember, I think that DC Greens has been the grantee or DC's grantee for this particular program. Was there a time when we had this as a multi-year grant as opposed to having to apply every year?
I'm newish here, but I think it's been annual every year, which, just adds burdens to both the government and, of course, to us.
Well, and of course, I think that the Produce RX has been incredibly successful in terms of helping individuals, providing that additional level of support of fresh fruits, fresh vegetables to aid in their overall health. And we did note that, let's see, it's January 27th and Healthcare Finance has yet to award that particular grant. There's some other grants that they have yet to award. So we'll certainly follow up and be asking some questions about that when they are there. I'm trying to be good about my time myself. But I know I can ask some of you guys way more questions, but then I also know I'm going to see some of you guys in the coming weeks at future hearings. So I want to say thank you so much for being here. If you could provide your written testimony for the record, that would be super helpful. Thank you.
Thank you very much.
Okay, we're going to go to the next panel. Chris Gamble, Dana Mueller, Trupti Patel, Chioma Ora, Daniela Gonzalez Ruiz, Will Doyle, and Carolyn Wakeman. Also, I'm going to apologize in advance that my interns are trying to break in, so they might pop up on the screen because schools are closed today. All right, for those of you who are joining us, if I called you, there'll be a little box that pops up on your screen to invite you to become a panelist, and you'll need to, affirmatively accept that invitation in order for you to be able to testify. All righty. Okay, I see Chris. Chris, when you're ready.
All right. Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Chris Gamble, and I'm a behavioral health policy analyst at Children's Law Center. Thank you for the opportunity to testify today. Access and care quality are primary features of the health system that DHCF is responsible for ensuring. Of the youth in foster care that Children's Law Center's guardians ad litem represented last year, 40% had a diagnosed or suspected behavioral health condition, but only half of those were able to access the services recommended for them. Even in the midst of local financial pressures and federal policy changes to the health sector, the district can and must prioritize the well-being of residents. My testimony today focuses on DHCF's work in behavioral health, while my written testimony expands on opportunities for growth in maternal health and uses of the 1115 waiver. The district currently has a bifurcated Medicaid financing model where many behavioral health services are carved out of managed care, creating complex payment procedures and preventing managed care organizations from exercising full oversight of those services. DHCF and DBH identified carving in behavioral health services as a solution to the disjointed financing structure back in 2019, but nearly 7 years later, after several delays, have no set plan for how to move forward. We raised this issue in recent meetings with Budget Director Jenny Reed and Deputy Mayor Wayne Turnage, and received encouraging feedback that there are viable steps DHCF and other executive agencies can take to move DC forward in making the carve-in happen. We asked the committee to speak with both officials before upcoming FY27 budget hearings to understand the steps towards implementing the carve-in and ultimately improving funding predictability and the quality of services. In order to get a more accurate picture of the accessibility of behavioral health services, the performance standards that MCOs are held to need to be expanded. Right now, the network adequacy and timeliness standards enforced by DHCF do not measure access in meaningful ways. The annual reports that assess MCO network adequacy score their performance as satisfactory, but the delays in beginning treatment and frequent turnover of clinicians that our clients experience suggest that the measures being used for MCOs don't adequately capture the experience of seeking care. DHCF has the opportunity to improve the quality of care available to youth in DC through the establishment of certified community behavioral health clinics, or CCBHCs. For years, the continuum of care for youth has remained stagnant in some areas while deteriorating in others. With CCBHCs, an enhanced financing model alongside federally determined service provision and quality measures offers a more stable model of community-based care that would be available to all ages, regardless of ability to pay. The district has completed a planning grant this year and is ready to apply for a CCBHC demonstration grant. We asked the committee to follow up with DHCF about progress in establishing this critical piece of the care continuum. Thank you for the opportunity to testify, and I welcome any questions you may have.
Thank you. Dana?
Good afternoon. Thank you. I am sorry, I am fighting a cold that my toddler gave me, but I am Dana Mueller, Vice President of Medicine at Mary Center, and more importantly, an internal medicine and primary care physician serving Medicaid and Alliance patients here in DC. I'm here today to share how the changes to the Alliance program that were implemented in October 2025 have affected my patients. And while this is one person's story, Mr. S's experience is being replicated across our community. Mr. S is a 72-year-old man who has had diabetes for 5 years. And like many of our patients, he felt well until he wasn't, and was not in medical care when he became ill in 2020. After hospitalization, he established care with me, and over time, we were able to get his diabetes under control. In September 2025, his A1C was 7.3%. This is a measure of diabetic control, and this is considered optimal. Unfortunately, following a burn that he incurred at work, he didn't heal appropriately because of his diabetes, and he had to have his leg amputated last spring. After surgery, he was able to get a prosthetic limb through the Alliance program, which would allow him to maintain much of his normal function and return to work. However, by the time he received the limb, the prosthetic, the cuts had come into place, and he was not able to realize the therapy plan recommended by his doctors. And he, because he cannot leave his home, so home health can't come to him, and he can't get to therapy. And so he does not use his prosthetic. His therapists have recommended that he be admitted to inpatient rehab. But as of his last visit to me in December, we were told that the decision to extend intensive inpatient services for this population was still pending. Without the limb, he can't get to appointments independently, and his daughters can't take any more time off work to provide him with transportation or support. Less active and without the medications that were previously covered, his December A1C was 11.2%, reflecting dangerously high blood sugars. I worry that losing insurance altogether in October 2026, when the financial eligibility requirements change again, will only further his decline. Even before the recent changes to Alliance, our diabetic patients had worse control of their diabetes than our overall clinic population. Just 41% of diabetic Alliance patients, as opposed to 65% of all patients in our clinic, had moderate or optimal control in the first half of 2025. Of the 24% of these patients who have returned to care since the changes to the program in October, 62% have higher average blood sugar now than they did before the change. I've been proud to practice medicine in DC, a city that chooses to uplift those who financially need our support, but we're legally unable to do so for over a decade now. This is a city that understands we're all better off when all members of our community have access to necessary health services. I ask that we return the income eligibility limits to prior levels, and we reinstate essential services and remove the age cap. Thank you.
Thank you. Trupti?
Good afternoon, Chairperson Henderson. Thank you for holding this performance oversight hearing and allowing for my testimony to be entered into the record. My name is Tripti J. Patel. I represent Single Member District 2A03, Historic Foggy Bottom, and I serve as the Chairperson of Advisory Neighborhood Commission 2A. I'm here today to speak about two issues that have directly impacted my community, encampment clearings and the Aston. I want to begin with the encampment clearings. My former colleague, Commissioner Yannicka Mickton, authored an ANC resolution raising serious concerns about the East Street encampment, how the East Street encampment was cleared by Deputy Mayor of Health and Human Services. Clearing encampments without a clear individualized housing plan is not housing first, it is displacement. For years, advocates have warned that this approach does not solve homelessness, it simply moves people from one location to another. This is not problem solving and it is not a responsible use of taxpayer resources. Many individuals living in encampments have already have housing vouchers and were waiting for placement. Clearing encampments without resolving that bottleneck only deepens instability and delays permanent housing outcomes. Encampment clearings are also deeply traumatic. Poor people lose medication, identification documents, and personal belongings. Trust in government erodes, making future outreach harder, not easier. The current approach is not humane, not sustainable, and not effective. Deputy Mayor of Health and Human Services must move away from reactive clearings and toward proactive strategies that prioritize permanent housing and continuity of care. I now want to turn to an example of what works. In May of 2023, the district acquired the Aston, a former graduate student dormitory at 1129 New Hampshire Avenue Northwest, to serve adults with acute medical needs, mixed gender adult families, and couples experiencing homelessness, populations often poorly served by traditional shelters. The Aston faced intense scrutiny and community divisions. As ANC chair, my priority was simple: get it right. A community advisory team, or CAT, was created to ensure transparency and accountability. The CAT's co-chair is Senior Deputy Mayor of Health and Human Services staff member appointed by Mayor Bowser, provided fair, ethical, and transparent leadership. That leadership transformed skepticism into trust. Because of this partnership, the Aston did more than open. It succeeded. It met its benchmarks, addressed community concerns, and demonstrated that high barrier shelters can operate responsibly and with community buy-in. The Aston has now been operating for 1 full year, and issues raised have been resolved promptly and effectively. For the past year, the majority of ANC2A has called for the cap on the Aston to be lifted. The Aston CAT has formally voted to support lifting the cap as well. In this case, Deputy Mayor of Health and Human Services got it right, and the cap on the Aston should be lifted. In closing, I close with 3 clear requests. Number 1, end the encampment clearings without guaranteed housing pathways. Number 2, expand the community advisory team model citywide. And I promise I'm done. And number 3, lift the cap on the Aston. Thank you for your time, and I'm happy to answer any questions.
Thank you, Tripti. Chioma?
Okay, good afternoon, Chairperson Christina Henderson. I am Chioma Oru. I'm the Health Justice Project Director at Advocates for Justice and Education. AJE is the federally designated Parent Training Information Center, the Family Health Information Center for District of Columbia, and a DC Title V implementer for DC children with children and youth with disabilities and special health care needs and their families. Deputy Mayor Wayne Turnage's FY 2025 testimony outlines difficult trade-offs, federal uncertainty, and real constraints facing DHCF and the broader Health and Human Services cluster. These realities are not lost on the families we serve. However, I'm here today to underscore a critical truth. The cost of not providing care, especially to caregivers, immigrant adults, and the working poor, will far exceed the cost of preventative, coordinated, and humane systems. What we are witnessing is not just a budget challenge, it is a slow-moving political pandemic that extends beyond insurance coverage into workforce stability, family unity, and public health resilience. Vulnerable DC families, especially those with children with disabilities, are being asked to absorb the shock. Working families are being punished for earning just enough to lose coverage, but not enough to afford care. Fathers, primarily Black fathers, are being structurally excluded from caregiving, while healthcare access tied to income thresholds does not reflect the realities of housing, transportation, and caregiving costs in the city. Immigrant adults, many of whom are parents, are now left to fend for themselves as Alliance coverage becomes uncertain for adults over 26. We are already seeing delayed care, increased emergency room use, and deep fear amongst mixed status families. Particularly transition age undocumented youth with disabilities are aging out of pediatric systems with no viable healthcare pathways ahead. This is why AJE echoes the urges of our coalition partners in the Keep DC Healthy campaign. First, with respect to DC Medicaid and DC Healthy DC, we urge DC to establish continuous enrollment period and grace periods for renewal so families are not abruptly cut off. Other demands are in my full testimony. I want to stress that yes, fiscal stability has to be a priority for DC, yet one thing missing from the analysis of the problems at hand: when caregivers lose healthcare, children lose care. Removing healthcare from parents, grandparents, and kin caregivers does not save money. It creates crises. The consequence are a snowball effect. The FQHCs absorb more uncompensated care. Behavioral health providers see higher, thus more unmanageable caseloads. Schools will have more unmet health needs without adequate solutions, and our public health system will continue to serve populations that are more stressed, more vulnerable, and less able to engage in prevention. Yet I remain hopeful because I trust all of your leadership and urge the Committee on Health to weigh not only the fiscal ledger, but the moral one. The cost of inequity is too high. The cost of care is an investment. Thank you for your leadership and your commitment to building a healthier, more just DC for all families. I'm here to answer any questions. And my colleague, Danielle Gonzalez Rios, is in the waiting room and needs to be let in. I think she's right after me.
Okay, we will promote her, but in the meantime, we'll go to Will as she logs on.
Yeah, thank you, Chair Henderson, council members, and council staff. My name is Will Doyle, and I'm the Vice President of Housing First, Pathways to Housing DC. I want to thank this committee and the Deputy Mayor for recognizing that the Court Urgent Care Clinic and DC's social work workforce are crucial to ensuring that children, youth, and adults with and without disabilities can lead healthy, meaningful, and productive lives. We deeply appreciate the continued funding and support we have received for the Court Urgent Care Clinic, despite immense budget pressures to eliminate it. As a result, our staff have continued to provide immediate access to mental health and substance use assessment and treatment at the DC Superior Court. In FY25, staff completed 897 unique intakes, which is 50% above our contract benchmark of 600 and 29% more than in FY24. Additionally, we conducted 1,078 assessments and 5,747 follow-up visits. In FY26, staff are on pace to complete 1,112 unique intakes, which is 85% above our contract benchmark and 24% more than in FY25. We are also on pace to complete 1,444 assessments and 6,344 follow-up visits. This exponential growth illustrates the ongoing and increasing need for this critical same-day behavioral health service. DC's funding of this program has been crucial in being able to provide urgently needed services regardless of client identification, insurance, or residency status. As we shift into budget decisions for FY27, we urge the Deputy Mayor and the Committee on Health to continue prioritizing funding for the Court Urgent Care Clinic. When we first asked the Deputy Mayor to support social work licensure reform in October 2022, we estimated that DC would have an additional 20 licensed social work associates, 285 licensed graduate social workers, and 169 licensed independent clinical social workers if DC had not been using flawed exams from 2011 to 2021. Having an additional 474 social workers in our workforce would have made an incredibly positive contribution to the health and well-being of DC residents. Recently, an educational pathway was implemented for licensed graduate social workers. This alternative maintains DC's high standards for health professionals by emphasizing the role of supervision in preparing and evaluating social workers. Between November 6, 2025 and January 16, 2026, 246 educational pathway LGSW licenses were issued. As of October 27, 2025, DC had 1,388 LGSWs. Therefore, DC increased its LGSW workforce by 18% in just 72 days. Thank you to the Deputy Mayor and the Committee on Health in prioritizing the needs of DC residents through this impactful change. Thank you for holding this hearing. I'm happy to answer any questions.
Thank you. Daniela?
Good afternoon, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to address the Council today. I am Daniela Gonzalez Rios, the Health Justice Coordinator at Advocates for Justice and Education. As many residents are losing insurance coverage through Medicaid and Alliance, my recommendations today focus on the steps the district should take to restore affordable and responsive care for DC residents. During the public roundtable on December 3rd, I emphasized the need for intentional outreach, responsive community engagement, focus group listening sessions, and one-to-one support to help families navigate these critical changes in DC's public healthcare systems. During that hearing, Director Turnage stated that the Department of Healthcare and Finance would convene an Alliance Advisory Council. His comments suggested an intent to recruit individuals who have worked with the agency previously and who understand the physical pressures and limitations associated with agency savings and constrained resources. While the Office of the Deputy Mayor for Health and Human Services and DHCF undoubtedly have capable and insightful staff to review and manage budget process, the Alliance Advisory Council should serve a different and equally important purpose. It must be a platform where advocates and beneficiaries have a seat at the table where they can participate meaningfully in decision-making and advocate for what they need rather than being told what they should need. We are not seeking groupthink, we are seeking representation, transparency, and inclusion. Individuals should not be excluded because they have not previously worked with DC's budget process. Instead, they should be welcomed to share their lived experience and help lead the city with leadership that is transformative, inclusive, and non-hierarchical. Furthermore, the Alliance services have been restored through the contingency list in the FY26 budget. The Council must ensure more transparency in the decisions that DHCF makes in this critical moment. Specifically, we request clear answers regarding when resource services will become available to residents based on additional funds discovered by the CFO, and when providers and residents will be formally notified for these changes. Along with other organizations testifying with respect to DC Medicaid, we urge the district to establish a continuous enrollment period for the Healthy DC plan, as well as grace periods for renewal when coverage is lost. We also urge the Council to commit to securing funds for dental coverage if Affordable Care Act subsidies are not extended or delayed at an estimated cost of $5.1 million annually. Additionally, we recommend securing funding for vision coverage for Healthy DC plan enrollees. Finally, we ask the DC Health Benefit Exchange Authority to pursue a Section 1332 waiver. Thank you for your time and consideration, and I welcome any questions you may have.
Thank you. And Carolyn.
Good afternoon, Councilmember Henderson. Thank you for the time to provide testimony. My name is Carolyn Wakeman. I'm a family physician at Mary Center. Been there since 2019. And my aim today is to talk about how the changes that the DC Healthcare Alliance program have had, particularly on our patients facing substance use disorders. Before the changes in October, the Alliance formulary covered all of the commonly used medications that we use in addiction. One of those being naltrexone, which is effective for both alcohol and opiate use. It reduces cravings and helps patients maintain sobriety. Naltrexone is available as an oral tab that patients can take at home on their own, and also as an injection that's administered in clinic by a provider, so that patients come into clinic, they receive the Vivitrol injection, and also meet with the care team to provide general support. Since October, the injected form or Vivitrol is no longer available, even when our team has requested prior authorization for patients who have failed with the oral naltrexone. To that end, some patients do really well with the oral tab. They take it consistently, they experience the benefits that I mentioned, and it's a good fit. But for other patients, particularly those who are at a more vulnerable place in their recovery, and thus already at increased risk for the harms that are associated with addiction, sometimes it simply doesn't work. And in order to receive the benefits of the naltrexone, they really need to be on the monthly injection. Because the burden is not on them to take a daily pill, which is hard to do. I think anybody who's been prescribed any medication can attest to that. This is something that providers with all of our medications are addressing with our patients on a consistent basis. And so it is incumbent upon us as providers, as a healthcare system, to remove that barrier for patients seeking treatment for addiction. As for them, the difference between missing a pill one day is not just missing that dose that day, but can be potentially the distinction between continuing their sobriety and a potential relapse. As an example of this, I want to share a story of a patient I'll call Anna. She was established with us as a primary care patient for years before she came seeking treatment for alcohol use after being hospitalized 3 times within the same month for alcohol intoxication and withdrawal, and alcohol withdrawal can be fatal. She works full time, mostly at night, because she's taking care of her children during the day, and doesn't have much family or community support. So inpatient rehab options were never, rehab programs were never going to be an option for her. She did start off with the oral naltrexone, and then quickly received, oh, my battery's gonna die, this is bad timing. Quickly switched, excuse me, to the injectable Vivitrol because she was not taking the pill consistently. When she was receiving her monthly
Carolyn? Okay.
We have terrible work laptops. I am sure that it is just her battery.
Okay.
I know
Oh,
she's
okay.
I expect that it will be up in a moment if you want it and she can finish. Yeah, our laptop battery. She was in clinic this morning, so our laptop batteries are not great.
Okay.
She says she'll be right back
Okay.
in a text.
Give that
Thank
a
you.
minute.
Maybe someone else wants to talk. If there, is she the last one?
She is the last one.
Okay. She is trying to get back on.
Okay, I'll just ask some questions of the panelists who are here. And if she's able to rejoin, we'll certainly allow her to finish. Thank you to this panel of witnesses for your testimony. I want to ask Chris Gamble. So in your testimony, you brought up something I actually caught that I thought was very interesting in the pre-hearing responses from Department of Healthcare Finance around network adequacy. And, you know, Healthcare Finance sort of reports that no NCO had any problems with network adequacy for any, you know, specialty or thing, which I found to be very interesting because I know that we've had problems with dentistry. Like I've had to call a MCO president myself to try to intervene on behalf of a patient who is having a really, really difficult time getting an appointment. What should our measure for network adequacy actually look like?
Well, so I think the issue with what the standards are right now is it's mainly just like geographical distance. You know, you have within behavioral health, it's like there's a therapist within 5 miles or within 30 minutes of you, I think is the standard, which, you know, really leaves out a lot of things that are important in the realm of behavioral health of like, well, what type of clinician is it? What particular type of therapy do they provide? Their scope of practice, like these are things that are more meaningful in terms of not just there's a person that exists close to you and thus meaning that the network is adequate, but like actually what type of service is available. Because if you're surrounded by 10 therapists, but none of them meet the needs of you or your child or something, then that's not doing much for you. So in the context of my testimony, I'm also looking at once we are looking forward to a future where there would be a carve-in where MCOs then have even more purview of all the MHRS behavioral health services. We just knowing that there's maybe like a CBI provider within within a few miles of a member doesn't tell you everything about even like the staffing of that place and like how long it would take for you to start receiving services. So yeah, I think there's just a lot more that can be added, a lot more detail. We have in our Path Forward report, there's a list of things that could be added there just to make those measures more meaningful so that, like you said, when we look at it and see that it's saying it's satisfactory, we can know that that is based on more detailed measures.
Oh, okay. Dana, or Dr. Mueller, you talked a little bit in yours specifically about alliance changes, but I'm curious also, we're trying to figure out how things are going on Healthy DC as well. Do you have any feedback on that particular program?
Yeah, I happened to listen to the group before because this is my first time testifying. And so I agree with them that it doesn't seem like it's entirely clear to end users yet, to to patients. They don't have their cards. They are pretty sure that their new plan covers dental and things like that, that we know it doesn't. I think there just hasn't, it's both a matter of not great communication and then also just, poor understanding of healthcare, right? And of how our system works. It's January. We're getting so many people who say, my med's $1,300 again. You have a high deductible plan. That's what a deductible is, right? But as far as I think we're not seeing it routinely yet. I asked when you asked in the last bit, I asked a group message of our providers, and I did not hear much other than the one or two people that they've seen have had unclear understanding of what's covered.
Okay. Yeah, I mean, this is the hard part, right? And I think this is the case for any sort of insurance company, even for private insurance. My private insurance company, they sent me a letter. I was like, here's your explanation of benefits.
Right.
They'll occasionally send an email that sort of talks a little bit about the thing, but how often do we actually open up the letter from the insurance company to sort of look and see and compare, right? What was offered before, what was not offered, and how does that differ? And so it's early. And part of the reason we did the transition that was sort of like, we're just going to put you as opposed to having people opt in was to make sure that there was continuity there, because we know that if it was an opt-in situation, even more people would sort of have fallen off.
Yeah.
But we're still trying to sort of assess on some of those things.
Yeah. Dr. Wakeman is available. She sent me a message after your questions.
Okay.
Yeah, thank you.
We will promote her back up again. Yeah. Mr. Doyle, are you still with us?
Yes, I'm here.
Okay. So as you know, right, the council has been able to save the funding for the Court Urgent Care Clinic for the last 2 years. And in fact, the first year, we had recurring funding, but then the chairman swiped that and used that for something else. And so we had to sort of patchwork it back together again. We had conversations with the Department of Behavioral Health and the Deputy Mayor's office about this. They were like, oh, well, we were talking to the courts to see whether or not they can cover it, which we know that they won't, because the courts are federally funded and the Department of Justice doesn't necessarily find this to be a positive. Have you all had any other conversations with the mayor's office about, the value of this program and how we can ensure that it can continue?
Not the mayor's office yet, but we can certainly follow up them if we can get conversations with that.
Okay. Okay. I don't have any further questions for this panel. Thank you all so much for being here. And if you haven't loaded your testimony for the record, please be sure to do so.
Thank you.
Okay, we're going to go to the next panel. Shannon Walsh, Ian Perigal, Ed Lazier, C. Nickel, Nadia Casey, Gabriella Farrell, and Keela Olagu. Giving a minute for folks to come on in. Okay. All right. I don't see Shannon, but I do see Ian. So, oh, it's Ian.
Ian, yes.
Sorry.
Good afternoon, Chairperson Henderson. How are you doing? I'm Ian Paragal, and I serve as the Exec Director of the DC Coalition of Disability Service Providers. The DC Coalition currently represents over 50 provider agencies supporting over 2,300 persons with intellectual and developmental disabilities, hundreds of persons receiving home health supports, and employing over 8,500 staff. On behalf of our provider agencies and those whom they support, we want to recognize the leadership of Melissa Bird, and in particular, the transparency and accountability demonstrated by Angelique Martin, as well as Sam Woldig-Horgus and Brian Balaba. Director Bird has always made herself available to provide direction and answer questions that arise in our sector as the coalition's primary conduit to fiscal matters relating to service delivery. Ms. Martin's follow-through and collaborative approach have helped provider organizations maintain quality and consistency for at-risk populations. Ably assisted by Mr. Woldig-Horgus and Mr. Balaba, DHCF has partnered with the coalition over the last several years in helping providers manage the potentially dire circumstances resulting from the pandemic and local fiscal challenges. Let me turn to my main issue today, which is DHCF's nursing rates. In 2024, an independent contractor hired by the district called Bazell US conducted a large-scale survey of DD and home health providers. According to the detailed Bazell survey, the 2024 hourly provider paid rate for a registered nurse was $43.54 an hour, while the Bureau of Labor Statistics rate at the midpoint was $50.59 per hour. The corresponding rates for an LPM were $30.50 per hour, and the survey wage paid, and the 50% BLS rate was $32.55. I have all this stuff detailed in my written testimony and a breakdown from Bazell with a chart on it. But the bottom line is providers are currently reimbursed by DHCF for nursing services at a rate of $28.88 per hour for LPNs and $46.27 per hour for RNs. Both rates are not only below the 50% trial from 2023, it's also well below what providers are actually paying for their nursing staffs in 2026. As a result, the DC Coalition again renews its request that is made for the last 3 years, urging the Health Committee to encourage DHCF to establish competitive funding rates to address nursing needs in the DD and home health communities. I provided some current DC-only wage data from ZipRecruiter, and Indeed showing the nursing market differentials in my written materials. But again, providers are funded by DHCF at $28.88 an hour and $46.27, irrespective of the trend. And to be clear, that 5 to 10% per hour shortfall equates to between $10,000 and $20,000 a year in lower wages, which is a significant deterrent to nursing recruitment. So what we are just seeking is that providers can pay a competitive nursing rate, and we recommend the hourly rates that form our reimbursement rates be adjusted. I know my time is up, and I will welcome any questions.
Thank you. Mr. Lazier?
Good afternoon, Chairperson Henderson. Thank you for the opportunity to testify. My name is Ed Lazier. I'm the Director of Legislative Advocacy at United Planning Organization, or UPO, which is the district's community action agency and has been working since 1962 to improve the economic security of DC residents with low incomes. I'm here to testify on the performance of the DC Healthcare Alliance program and Medicaid. As you know, the budget for FY26 made sudden and dramatic cuts to healthcare benefits and income eligibility, affecting thousands of residents. The testimony you've heard today already is a reminder of how budget decisions connect to performance results. The fact that the budget included multiple complex cuts in a very short amount of time almost guaranteed that many residents would fall through the cracks. It's a reminder that in situations when cuts are needed, off-ramps, guardrails, and other steps are needed to make sure that affected residents are protected as much as possible. I echo the sense of urgency that others have made today to create the Advisory Council for the Alliance in terms of monitoring what has happened and to ensure that the contingent funding that's been approved is now implemented with clear communication to residents and providers. I also would like to know what DHCF is doing to direct Alliance recipients to other services, again, part of those off-ramps and guardrails, such as through Department of Behavioral Health, and indeed whether other services are in fact available and accessible. I urge you to keep your focus up on the performance of the DC health system following these dramatic cuts. How are the cuts affecting the health status of DC residents? How are the cuts affecting the wide range of health providers? What gaps are the worst? Today's gathering should not be a once-a-year event. These are really dramatic changes, and I hope you'll stay on top of monitoring how the effects are happening. The issues are, of course, important, but really the most important issue is the restoration of Alliance coverage for those who've lost it, 25,000 residents over the next few years. As budget season approaches, UPO supports full restoration of the Alliance. We also support efforts to address the Medicaid changes made last year. We urge you to ensure that there's a continuous enrollment period for the Healthy DC plan and grace periods so that people don't, again, fall through the cracks if they do not maintain their basic health plan eligibility. We urge you to, and the council during budget season, to secure full funding for dental, vision, and long-term care in the basic health plan. And I think I'll stop there. Thank you so much for the opportunity to testify.
Thank you. C. Nickel.
Good afternoon, Chair Henderson. My name is C. Nickel, and I'm the Community Health Outreach Manager at First Shift Justice Project, an organization that assists DC workers in asserting their health-related workplace rights. While we don't provide direct healthcare services, our work intersects with the healthcare system because in order to access health-related workplace protections and entitlements like DC paid family leave, workers have to have access to healthcare. As an organization that supports workers in DC, we see how access to healthcare impacts workers' ability to maintain stable employment. When healthcare access is cut, it creates ripple effects. Workers might lose access to critical treatments or face restrictions in their ability to get care when they need it, which leads to a deterioration in health, causing workers to miss more days of work. In some cases, it might also cause them to lose their jobs altogether. Without access to healthcare, workers are unable to get medical documentation that they need to exercise their workplace rights, like requesting accommodations or taking job-protected leave. As a result, they're vulnerable to termination or being forced to take unpaid leave, which leads to additional financial strain. The cycle of poor health, job instability, and financial insecurity is a reality for many workers in our community, and this cycle can be prevented by ensuring that Alliance remains accessible to those who need it. Workers who fall in the healthcare gap rely on Alliance to access essential healthcare services, and for many, as you've heard today, Alliance is the only option for access to affordable care. To ensure that workers and families have access to healthcare through Alliance, I urge the Council to take the following actions. First, to expedite the release of contingency funding. The contingency list was certified on the 24th of December, but the funds have not yet been implemented. So ensure the agency announces when the services restored via that contingency revenue will be available to Alliance recipients. If we truly want to support the health of DC residents and the stability of local workforce, this funding needs to be released immediately. Second, convening an advisory council for Alliance. As was mentioned before in the December roundtable, Director Turnage said that DHCF would convene an advisory council for Alliance and that agency should take action to actually do that. And third and lastly, ensure that providers and residents are informed about changes. We need clear communication about three things. First, what will be covered. Second, when services will be restored. And three, when residents and providers will be informed of these changes. It's essential that we don't leave DC residents and their medical providers in the dark about their healthcare options. Patients and providers need to know what the start date for this expanded coverage is, including if there are any coverage options for Alliance recipients out-of-pocket costs since the changes in October or the certification of the contingency list in December. The delay in communication and action only exacerbates the harm to families and workers who rely on these services for their health and economic security. The changes of Alliance have far-reaching implications that extend beyond healthcare. So thank you so much for your time and all that you do to advocate for commitment to improving health.
Thank you. I don't see Nadia, but I do see Gabriella.
Yes. Hi, good morning or good afternoon, Chairperson Henderson and members of the committee. My name is Gabriella Farrell, and I'm a Ward 1 resident and advocacy associate at Ayuda. Thank you for the opportunity to testify on behalf of Ayuda regarding the devastating cuts to DC Healthcare Alliance. For over 50 years, Ayuda has served low-income immigrants in DC through legal, social, and language access services. Our clients include working parents, elders, survivors of violence, and people whose lives and labor are part of the city. For many, Alliance is their only access to healthcare, and losing it can cause health and financial harm that is both immediate and often irreversible. And across our work, we have seen the critical importance of Alliance. For example, one of our clients was in a hit and run accident while biking to work, suffering multiple broken bones, and he would have faced a hospital bill of $95,000. However, because he was covered by Alliance, he received emergency care without lifelong medical debt. Many other of our clients have received care through Alliance, from cancer treatment to diabetes management to vision-saving medication. But unfortunately, we are also already seeing the impact of the recent cuts to Alliance, and the age cap has been particularly devastating. One of our clients, a 71-year-old unhoused immigrant who has lived and worked in DC for decades, can no longer access physical therapy for her autoimmune disorder because she no longer qualifies. The age cap and the lowered income limit cut residents off from the care that they need simply because it's been decided that they no longer qualify. And while the identification of contingency funds suggested some relief, providers and residents have not seen those restorations in practice. Vision and dental services remain inaccessible, forcing residents to bear the health and financial costs of this inaction. And the consequences of this delay are not abstract, they directly put DC families at risk. Protecting the health and safety of our neighbors must come first, and meeting that responsibility is well within the Council's power. IULA urges the Council to take seriously today's testimonies and fully restore the DC Healthcare Alliance. This means returning income eligibility to 215% of the federal poverty level, restoring all services covered prior to October 1st of 2025, removing the age cap for adults 26 and older. The Council must also ensure that timelines for contingency funded restorations are clearly communicated, as mentioned in other testimonies. And these steps would stabilize care for thousands and reaffirm that DC does not abandon people or quietly shrink life-saving programs. Even with real constraints, the budget must reflect our priorities, and fully restoring Alliance would reflect DC's commitment to governing with evidence, with responsibility, and care for its residents. Thank you for the opportunity to testify today.
Thank you. Keela?
Hi, good afternoon, Chairperson Henderson. My name is Kelia Oluhu, and I serve as the Program Manager for the North Family Partnership Program, NFP. Thank you for the opportunity to speak today. NFP is an evidence-based home visiting program that pairs first-time parents with registered nurses, beginning early in pregnancy and continuing through the child's second birthday. Last year, our program expanded in Ward 7 and 8 to serve not just first-time parents, but also parents with multiple births, allowing us to reach more families with increasingly complex needs. Our program outcomes demonstrate its effectiveness. In 2024 through 2025, 80% of participants initiated prenatal care in their first trimester and recorded 1 preterm birth among 42 births. We also continue to see strong rates of breastfeeding initiation and improvement in maternal health behaviors. Beyond clinical outcomes, our nurses support emotional wellness, housing stability, parenting skills, and future planning. We're not just improving health outcomes, we're changing life trajectories. The impact of our work is reflected in the voices of the families we serve. One participant shared, "I feel like I have grown from where I was at first. My home visitor is always patient when it comes to talking about how I feel. I have learned to never doubt myself. I am proud that I graduated high school at 18. I have more goals that I am working towards for me and my child. I hope that the next person can accomplish everything they say they want to do like I have so far." We're grateful for the funding allotted to our program in the current fiscal year 26 budget, which would allow us to hire an additional nurse home visitor and increase our capacity to serve approximately 25 more families. This continued support affirms the Council and the district commitment to maternal and child health, so thank you. However, despite this allocation, we are now several months into the fiscal year and have not yet received the formal notice of award. This timing has presented a challenge in previous fiscal years as well. As a result, our ability to hire, plan program operations, and implement services as intended is constrained. For example, at present, we are unable to begin the hiring process for a new nurse home visitor. It would be helpful to review the funding and award timeline to support smoother program implementation in the future. Finally, I have seen the many ways in which our program has supported families, and I would like to see it continue to do so. Recognize that to thrive as a program, we require sustained and sufficient funding. With the anticipated Medicaid reimbursement for home visiting yet to materialize, we face the challenge of sustainability, including limited funding, impacting our ability to serve families and retain skilled nurses. Thank you for the opportunity to testify here today, and thank you to the Council for continuing to prioritize the Nurse Family Partnership Program and protect the critical work we do. Thank you.
Thank you. Dr. Wakeman is back. I think. I hope. She's here.
Yeah. Thank you so much. I appreciate the time to come back. My charger is fully in place. I was talking about my patient, Anna, who had been still having cravings and relapsed on the oral naltrexone. So she switched to the monthly Vivitrol injection. And with that, she told providers that she was not having any cravings, that she was able to be around other people drinking without cravings. And in her own words, was doing things with her children that she had never done before. She had about a year's sobriety with the monthly Vivitrol injections, and then actually wanted to go back to the tabs. And unfortunately, at that point, we lost her to follow-up. She reappeared in clinic after another hospitalization, after a relapse. And that cycle continued a little bit for about a year or so until last summer. When she came back, she got restarted on the Vivitrol. She was taking that monthly and was sober and has been sober. And then in our October visit, we had to inform her that her Vivitrol was no longer covered, and she was open to going back to the tabs. We have her on the tabs. I hope it will work this time for her, but it's really distressing to have a patient who has been shown to not have a good response to a medication, not have the access to the one that was so effective for her. And we have several patients, many patients in the same boat as she is. So I'm grateful that Alliance exists. I'm glad that allows so many of our friends and neighbors to seek and access medical care that every human deserves. But I'm genuinely worried with these sudden changes with certain medications no longer available at all, that we're going to see real harms in people's health. So thank you for the time. Thank you for bringing me back. I appreciate it.
Thank you. Nadia?
Hi, good afternoon, everyone. Hello, Chairperson Henderson and members of the Committee on Health. My name is Nadia Casey, and I serve as the Regional Executive Director for Gaudenzia Regional Addiction Prevention Incorporated, known as RAP. Thank you, Chairperson Henderson and the Committee on Health for holding today's performance oversight hearing for the Deputy Mayor for Health and Human Services and the Department of Healthcare Finance. I want to thank Mayor Bowser, the Department of Healthcare Finance, and Deputy Mayor Wayne Turnage for their leadership and service in addressing substance use disorders across the district. I'm honored to testify here today on behalf of RAP, which has been in the district for more than 50 years. We are an indispensable provider of substance use disorder, SUD, treatment services to the district's most vulnerable residents. RAP is the only district entity that provides a full continuum of SUD treatment services and is the sole safety net provider. Our services include SUD crisis stabilization, 24-hour observation, walk-in assessment and referral, withdrawal management, high-intensity residential treatment, low-intensity residential treatment, and intensive outpatient and standard outpatient treatment. RAP serves the district's most vulnerable and underserved residents, those living in the intersection of substance use disorders, serious mental illness, poverty, and multi-system involvement. This includes older adults with opioid, stimulant, and other substance use disorders complicated by serious mental health needs and a history of suicidal ideation. We also serve adults with co-occurring disorders such as HIV and physical disabilities, and of course, those who have recently been hospitalized or involved in the justice system. We support their residential SUD treatment needs and predominantly rely on the district's Medicaid fee-for-service program, the district's Medicaid managed care organizations, and the U.S. probation offices, and of course, the court services. With 78% successful treatment completion rate, which is well above the national average of 60%, RAP demonstrates that recovery is possible, stability is achievable, and community health can be restored. The demands for comprehensive SUD and co-occurring disorder treatment has only grown as the overdose crisis deepens. Poverty is a powerful driver of both substance use and untreated mental health needs. It creates chronic stress, fosters depression, and often limits an individual's ability to seek or sustain treatment. The district has made significant investments in SUD diagnosis and treatment, including residential treatment services, under immense strain. Many days, individuals seeking residential SUD treatment through RAP must be turned away, though, to limited capacity. Without immediate access to residential care, these same folks risk overdose, worsening health conditions, or continued penetration or entrenchment in the justice system. At this time, the co-occurrence of HIV and SUD in the district demands integrated coordinated services that can prevent infection, detect disease early, and link people to life-saving care.
Thank you. If you could just
I just want to ask that we look at the residential SUD reimbursement rates and look at the capacity in the city specifically for SUD treatment, focusing on residential care. At this time, the reimbursement rates are lower, significantly lower than our affiliated Maryland and Virginia area. And I thank you for this time.
All right, thank you. Thank you to this panel of witnesses for your testimony. Kalia, we heard from someone else earlier about grants that have not yet been awarded out, and we are tracking the home visiting grant. So we'll certainly follow up with Healthcare Finance, see what's going on there. They also haven't awarded the diaper bank grant yet either. And usually Healthcare Finance is more timely than some of the other agencies with their grants. And so we're going to definitely dig into try to understand better what is the holdup there. Dr. Wakeman, thank you so much for sharing the testimony, or for coming back to share your testimony, but also to share the experience of one of your patients. This is one of the hard parts around how do we provide some like continuity of care in the midst of this transition, and sort of recognizing that things are a little bit different at this particular stage. I mean, even with the 21 million that is in the contingency, it won't be enough for us to basically put all of Humpty Dumpty back together again and go back to where things were even before August of 2025. And so we're trying to work very closely to see what happens there. Mr. Lazier, are you still here?
Yep.
Okay, I'm going to ask you this question, and it's not anything that is sort of baked, but we're just going to test it out on you just for a second here. We have a bill that's currently pending that is around Medicaid buy-in for individuals who have disabilities, right? If they're wanting to buy in to be able to get some of the additional services, et cetera. And we're still working through that. And of course, Healthcare Finance will tell us like it's going to cost X amount of things in terms of additional infrastructure, et cetera. What if there was a similar type of program that introduced cost sharing with regard to Alliance? Obviously, I have no details here. This is just a thought.
Well, I appreciate the question. I appreciate you exploring options, and happy to do a little bit of research. I do generally know that when you're talking about folks with very low incomes, certainly like below 100% of poverty, that the minute you involve any sorts of copay, people just make that decision on today, can I afford my medication? Today, can I afford to go to the doctor or not? And if they can't, they don't. And then they just spiral downwards. I don't know if the research might suggest that folks at a higher income level would see it in their, would understand and be able to set aside the money to make a copay. It would have to be modest no matter what. I mean, we're still talking about for a family of three, income of under $50,000, which obviously is just not a lot in DC given all the other expenses. And generally folks are not eligible for other public benefits when they're seeking the Alliance, so they are living entirely on their earnings. So I, again, appreciate the question. I will do a little bit of research and get back to you and your staff.
Okay, I would just say this because one of the things that now we're kind of running into is that because there are eligibility changes that happened on Medicaid, for so long, Medicaid and Alliance had parity, right? Or that was the argument, right? We want parity, we want parity. And now it's different. And so, I don't know, that wasn't a well-baked idea, but it was just something that I sort of thought of. We just have to kind of figure out what are we going to do here across the board. But this is why we need the advisory committee would have this great opportunity to bring people together to have these different types of conversations. Okay, I don't have any further questions for this particular panel. Thank you so much for being here. If you can provide your written testimony for the record, we're gonna head to our next panel of witnesses. Louisa Batiste, Evagina Ordavoa, apologies if I'm butchering your name, Joshua Drumming, Elena Eckner, Christy Rispris, Kurt Gallagher, and Matthew Magyar. Again, you have to affirmatively accept our invitation to become a panelist. Give it a minute. Okay, I see Louisa.
Good afternoon, Councilmember Christina Henderson, and the members of the DC Council Committee of Health. Thank you for the opportunity to address the council today. My name is Louisa. I'm a resident of Ward 1 and a participant in the Nurse Family Partnership here in DC. I'm here to testify about my experience in the program, which I have been part of since I was 2 months pregnant. I now have a 20-month-old child. The support I received during my pregnancy was pivotal and ensured that I had access to resources I needed and felt informed and supported every step of the way. My nurse taught me how to advocate for myself with doctors and how to ask important and informed questions about my care. When I was 37 weeks pregnant, the birthing center I was supposed to give birth in had a fear that my pregnancy would be high risk. And at the last moment, I had to find another hospital to give birth. And my nurse was pivotal in ensuring that I got transferred to a hospital and that the care for me and all of my records were there too. And after my child was born, my nurse continued to provide consistent support. We received developmental milestones. We discussed upcoming pediatric appointments, and she checked in on me to make sure my child was growing and thriving. Instead of turning to WebMD, I reached out to my nurse, Genia, who helps me understand. Genia, my nurse, she's actually going to speak too, but she's responsible and just helps me understand like what's happening in my care and also in my child's care, and then supports me in just like asking the right questions when I do have to go to the doctor and do visits. When Genia visits, she always checks in about my own well-being as well as my child's. She also allows me to take the lead in my learning. It helps me shape visits around my needs. She has supported my child's development by providing age-appropriate books and activities. She guided me through major transitions like moving my child to his own bed and weaning him off the bottle. She also supported me in managing the OSSI childcare system so I can return to full-time work and ensure my child received the care he needs. As a new parent, she also ensured my child had essentials like a winter coat, hat, and gloves. As this program grows, I hope it continues to provide families with critical support such as winter clothing, cribs, bassinets, strollers, and just as importantly, knowledge. This program plays a pivotal role in reducing Black maternal mortality. And as a new mother, having a trusted nurse as my first line of support helped me understand what was normal and when to seek care. She gave me the language and confidence I needed to advocate for myself. I'm deeply grateful for the NFP team and the Mary Center. The work they're doing is essential in supporting new mothers and families. And I urge you to continue investing in the program. like this because it truly saves lives. Thank you.
Thank you. Genia?
Hi, thanks, Louisa. Dear Chairperson Henderson and members of the DC Council Committee on Health, thank you for the opportunity to testify today in support of dispersing the allocated funding for home visiting services. My name is Zhenya. I'm one of the home visiting nurses for the Nurse Family Partnership of DC at Mary Center. Home visiting services families who are often already living at the edge of multiple systems, healthcare, housing, public benefits, that are increasingly unstable and difficult to navigate. Right now, as political uncertainty threatens social safety net programs, which many of them have been cut even at our institution, the need for home visiting has never been more urgent. As a nurse home visitor, I see every day what happens when even just one support is removed. Families lose benefits that they rely on, miss critical care because requirements are confusing or contradictory, lose their healthcare access due to the new changes, and fall through the gaps that no one else is watching. For the families I serve, these losses are not abstract, they are devastating. For one participant, a parent with cognitive and developmental disabilities, Nurse Family Partnership might be the difference between being able to parent safely and confidently or not being able to parent at all. With consistent nurse-led home visiting, this family is able to keep their children in safe childcare, access early intervention, secure stable housing, provide appropriate nutrition, and remain connected to medical and mental health care. Without the support, families are often left to navigate impossible circumstances alone. NFP nurses routinely identify serious concerns before they're recognized elsewhere. Mental health crises, developmental delays, chronic illnesses, pregnancy complications, intimate partner violence, social needs that are unmet. We are prevention, early detection, and care coordination all at once. I want to share one story that illustrates what it looks like in real life. I worked with a new mother who had a long history of being dismissed and harmed by the medical system through systemic racism and discrimination while experiencing very significant health challenges. Through Nurse Family Partnership, she found a professional who listens, believes her, and who respects her autonomy. After giving birth, she developed severe postpartum depression. When she reached out to her psychiatric providers, she was told to tough it out, that it was just part of being a mother. This was told to her when she was having thoughts that her child would be better off without her. Postpartum depression is not benign. Suicide is the leading cause of death in the first year of childbirth, after childbirth. And untreated postpartum depression significantly increases the risk of maternal suicide, infant neglect, long-term developmental harm to children. Because of what this parent learned through NFP, how to recognize symptoms, how to advocate for herself, she knew this response was not acceptable, that it was not safe. She contacted her NFP nurse, and the same day, through intensive support and care coordination, she was connected to appropriate mental health care and treatment plan, and today she's a thriving parent. I'm going over time a little bit, but as you know, many families really need this level of support. So I urge you to help us get the funding that was allocated for NFP and to continue to work on Medicaid reimbursement. And thank you so much for the past support and your support for home visiting in general. Thank you.
Thank you. Joshua?
DC and Cayman residents have long been under siege, but are now likely in the most precarious position they've ever been in. As we testified to during the last oversight and budget season, DMHHS has decreased their notice period from 14 to 7 days, but following both the executive and mayoral order, DMHHS oftentimes bypasses notice altogether through their use of immediate dispositions, more so than they already did. Immediate dispositions allow DMHHS to clear encampments without notice on the website or at the encampment site, as long as DMHHS claims they pose immediate risk to health and safety. Encampment clearance can too easily qualify as immediate dispositions due to the nebulous nature of the public health and safety determination. Justifications for determinations aren't shared. As a result, encampments that appear to be no different than any other and pose no actual public risk are often swiftly dismantled and their residents are dispossessed. Often, immediate dispositions are used for single persons. Those encampment residents often receive little to no outreach before clearings, and posted signage may not even be visible. Once clearings begin, all or nearly all belongings are thrown away, despite DMHHS's mandate to store non-trash items. The seizure and destruction of belongings during immediate dispositions without notice or adequate notice, the requisite risk factor, due process, or post-deprivation proceedings, are likely unconstitutional and will potentially lead to unnecessary litigation. Increased encampment clearings and immediate dispositions have created unnecessary chaos and outreach disruptions in DC. To be clear, the joint presidential and mayoral efforts to clean up or beautify DC and the resulting decrease in encampment visibility are not evidence of a decline in district homelessness. Unhoused residents have been forced to relocate, but they still exist. DC homelessness still exists. In the last year, without first being offered housing, unsheltered DC residents have been dispossessed by the dual forces of DMHHS and federal agencies. Last year, President Trump issued an executive order targeting all encampments on federal land and creating an encampment eviction task force meant to coordinate with local officials to clear DC land as well. Last August, the legal clinic witnessed a large group of law enforcement officials composed of MPD, FBI, and Secret Service descend upon a small group of encamped residents located at Washington Circle. These were residents who had already received notice of a pending clearing by DMHHS for a future date. Despite that fact, these residents, to their detriment, relied on the assumption that they could trust dates on DC government notices. Ultimately, they were forced by law enforcement to relocate days earlier than expected. This is but one example. We've met multiple unsheltered DC residents who have been pushed around the city with their encampment targeted almost as soon as they've relocated. Some individuals have reported leaving DC to prioritize safety and avoid the uncertainty that now comes with being unhoused in DC. Months later, we have far fewer visible encampments and more primarily Black DC residents displaced throughout the district and out of DC due to the fear of potential law enforcement interaction. It's not yet clear the extent of the harm that's been done to DC's unsheltered community as a result of the increased clearings. DMHHS's cooperation with the federal government is still unclear, but the harm is empirically evident when walking down DC streets. Unhoused DC residents have retreated further into the shadows and become fearful of the DC agencies that are supposed to be concerned for their safety. We urge council to evaluate the encampment protocol and create legislative policies that standardize definitions and requirements for encampment evictions of all types, establishing due process for encampment residents, and minimizing opportunity for random and politicized encampment evictions. We say council enforce prohibitions against law enforcement engaging in pretextual stops that hinge upon race, ethnicity, and housing status. Council should suspend all encampment clearings. Instead, DC can conduct trash-only cleanings, provide additional trash cans in encampments, and maintain portable bathrooms and hand washing stations. All DC efforts to direct or cooperate with federal government targeting of encampments should be suspended. It's necessary that DC Council send a message that everyone, regardless of their socioeconomic or housing status, is welcome in DC and that DC intends to protect and support all of its residents.
Thank you.
Thank you.
Elena?
Good afternoon, Councilmember Henderson. My name is Alana, and I live in Ward 1, and I'm the co-director of the DC chapter of the National Domestic Workers Alliance. I'm here testifying about the Department of Healthcare Finances Administration of Alliance. I remember right around Christmas, one of my colleagues received a phone call from one of our members. She lives in Ward 1, she cleans houses, and she was crying tears of joy when she heard the news that the cuts to the Alliance healthcare program that she had already experienced loss of services would be reversed because of the certification of the contingency funds. And that was the deep relief of how much it means to people to have the security of healthcare. And so I want to make sure the council does everything it can with its oversight powers to make sure that this reversal of the cuts to services is as real for as many patients of the Alliance as possible. I want to just add my voice to what others have said about the importance of your role in pushing the Department of Healthcare Finance to use the certified contingency funds to restore as many services that have been lost as quickly as possible, to ensure patients and providers have transparent information about when and how that's going to happen, and to push for the advisory council that Director Turner mentioned in December to happen as soon as possible. In my experience, which I've had a lot of working with community members and trying to help them access services from the government, it always works a lot better when the government proactively shares key updates with stakeholders, with community members, and has groups like this advisory council where stakeholders directly share what they're seeing on the ground. And so I hope that will convene soon. And the worker that I mentioned that was so happy when she heard the news, she knew about it because she's connected to our organization and she's in advocacy spaces. But most domestic workers in DC are not aware that there were funds certified to restore some of these services that were lost, and they won't know unless the agency makes sure that patients and providers have clear information about restoration of services. Kristen from DC Appleseed and you were talking about the long-term care crisis in DC, and many of the domestic workers in Washington who are part of our organization, they do just that. They provide long-term care services for seniors who desperately need it, and there's a huge shortage in those services, and many of those workers are immigrants who can only get health care through the Alliance, many of them in home care and other industries of domestic work. It's just absolutely routine that they do not receive any sort of health coverage from their employers. And on top of that, these are really physically taxing jobs. If you ever tried to lift a senior every single day, you will have chronic pain, you will have long-term health injuries. And so it is essential to have access to health care. I'll just say that there is also this continued culture of incredible fear. Immigrant workers who are so scared to ask for anything from their employers, paid time off, a basic contract, access to workers' compensation if they're hurt. So not having insurance just becomes one more barrier. And it's really the last thing people need right now. So I'm just here for nannies I know who receive surgeries through the Alliance, who could not otherwise, caregivers who need their heart medication who have spoken to me, cleaners who have suffered workplace injuries, to thank you for your continued advocacy to push for this really key lifeline for our immigrant neighbors in DC. Thank you.
Thank you. I don't see Christy, but I do see Kurt.
Good afternoon, Chairperson Henderson and members of the committee. Thank you for the opportunity to testify this afternoon. My name is Kurt Gallagher, and I'm Executive Director of the DC Dental Society. I'm here to testify on behalf of our more than 400 dentists who care for the DC population. First, I'd like to express appreciation to this committee, Mayor Bowser, Deputy Mayor Turnage, and other administration officials who made it possible to increase Medicaid fees last year under Medicaid. This is the first increase for dental fees since 2007. And Mayor Bowser described it as an important first step. In that first step, 125 dental codes were affected by an increase. We understand after discussions with DHCF that it's not likely that there'll be an increase in fees for the 2027 budget. We're optimistic about 2028. Those fee increases are important for ensuring that dentists are adequately compensated for the work that and care that they provide. And it's also essential for ensuring an adequate network of providers under Medicaid. And lastly, as this committee considers activities related to the development of the budget, I do want to speak on behalf of those residents who lost Medicaid coverage this year. As you are aware, unfortunately, the Healthy DC plan does not include coverage for dental care, and that creates a lapse in coverage. Those residents may be okay for the next few months, but if the lapse in oral care coverage extends into 2027, we can expect significant and severe health consequences resulting. Oral health conditions can contribute to systemic diseases like diabetes, cardiac conditions. And in those cases, when a member of the public experiences those emergencies, they often head to an emergency room. Unfortunately, emergency rooms are not well equipped to handle dental emergencies. They may be able to provide pain relief, maybe lance an abscess, provide antibiotics, but ultimately the patient will need to see a dentist to receive care and treatment that is lasting. Without the coverage of oral health care under the Healthy DC plan, those members of the public in DC won't have access to those care except through emergency rooms. So thank you for hearing my concerns about ensuring that adequacy of both the network and plan coverage continues and is expanded to include oral care under the Healthy DC plan in the future. Thank you.
Thank you. Dr. Magyar?
Chairperson Henderson, council members, DHCF team, thanks for the opportunity to provide testimony on this topic today. So my name is Matt Major. I'm a pediatrician in Washington, D.C. I am speaking today, though, as the vice president of the D.C. chapter of the American Academy of Pediatrics. The DC AAP is the Washington, D.C. chapter of the National AAP and represents over 450 local pediatric healthcare providers. As pediatricians, we see firsthand the importance of healthcare coverage for our patients, as well as their families. And so we applaud the DC Council and DHCF for having built a strong program of coverage through programs including DC Medicaid, the Healthcare Alliance, and the former Immigrant Children's Program. However, I am here today on behalf of the DC AAP to share our concern around the ongoing changes in the Alliance administration, including enacted and possible budget cuts. We do urge the Council and DHCF to ensure that the Alliance continues to serve all children, young adults, and parents, regardless of their immigration status, and to work towards restoration of the Alliance as previously structured, including restoring services via contingency revenue. We provide care to patients and families in clinics and hospitals where up to 80% of our patients may be enrolled in Medicaid or programs like the Alliance. We take care of newborns up to the age of young adults, up to the age of 22 in our hospital, and personally can see how having good healthcare and insurance coverage enables DC youth to thrive and access the services they need to grow and develop into happy, healthy, productive adults. However, through our work, we can also see how the same coverage enables benefits for their older family members and parents as well. Our patients include many who have immigrated to the United States, and we know that it can be challenging to provide for their healthcare needs. We greatly appreciate the role that the Alliance has done already and continues to do in ensuring that all children in the district have access to healthcare, and commend the Council for maintaining coverage up until the age of 21. However, with the ongoing changes in Alliance coverage, we are worried about what has and what may happen to their parents and relatives in the days ahead. Ongoing coverage changes can leave caregivers more vulnerable to ill health and difficulty caring for their families. Furthermore, we are concerned that these changes will have a chilling effect on maintaining or re-enrolling children eligible for coverage in the Alliance. When families lack comprehensive coverage, it can make it harder for them to engage our healthcare system, and it can make it take a longer time. When families cannot access these services, we see increased emergency room use and access to the hospital, and these services are more expensive to maintain and cover, including for our hospitals, for our patients, and for our taxpayers as well. Inclusive coverage can save lives, improve health, education, and work potential, and lead to a stronger adulthood. And so ultimately, we do urge the Council to work with restoring services covered by the FY26 contingency revenue plan. We also urge the Council to work towards restoring the income limit for coverage and services previously covered by October 1st, 2026. Illness and disability can affect us at any age, and so we would also encourage an easing of the age cap for adults as feasible. Thank you so much to the Council for the time today. I'm happy to answer questions if needed. Thank you.
Thank you. And thank you so much to this panel of witnesses. So I have a couple. So Louisa and Genia, who testified earlier about home visiting, while you were testifying, we got a text from Healthcare Finance that they're preparing to award the home visiting grant. So hopefully there should be some updates on this fairly soon.
Thank you.
There was that. I wish I had more positive updates on all the things that everybody testified on, but that's what I have for now. Mr. Gallagher, thank you for being here and for your continued advocacy on not just on behalf of dentists, but of course on behalf of patients writ large. We continue to push in terms of dental coverage, restoring dental coverage both for Alliance as well as for a Healthy DC. And I'm hoping for us to have some updates from the executive on some of those choices soon. But we'll have to see. Mr. Drumming, I'll certainly ask the deputy mayor about, we noted in terms of the data, the number of increased encampment clearings that happened in fiscal year 2025. I suspect I know some of the reasons that they will point to. None of them will be satisfying, but we'll certainly talk to them about what ways in which we are, again, still working to increase the amount of housing that's available for folks, so folks don't feel like they have to be in an encampment to have access to safe and accessible shelter. Dr. Major, thank you for being here and for the continued advocacy and work of the American Academy of Pediatrics. Your jobs of you and your members have gotten so much more difficult and yet critically important over the past year and the last few months. And so, thank you for being here and advocating on behalf of your patients as well. I don't have any other questions specifically for this panel of witnesses. If you could just make sure that you provide your testimony for the record, that would be helpful. Thank you. Okay, we're going to go to the next panel. Dr. Clint Peebles. All right, 41 has already gone. Crystal Jackson, Holly Eaton, Fernanda Ruiz, Gabby Salato, Lisa Queen, and Claudia Sosa. Okay, I'm trying to give it a minute as folks come over. Okay, I do see Dr. Peebles when you're ready.
Thank you. Good afternoon, Chair Henderson. Good to see you, and thank you for the opportunity to testify today. My name is Clint Peebles, and I'm the president-elect of the Medical Society of the District of Columbia, which is the largest medical organization representing metropolitan Washington physicians in the district. We advocate on behalf of all 11,000 plus licensed physicians in the district and seek to make the district the nation's model for patient care and physician practice. I'm pleased to represent MSDC today and provide comments on the Department of Healthcare Finance's performance over the past year. My overall and most pressing comment is that I want to thank DHCF for being a partner to the Healthcare Association community over the past year. MSDC is a proud member of the Medical Care Advisory Committee, a role where our Executive Vice President serves, and we appreciate the open lines of communication we've maintained with DHCF staff, and I want to thank in particular the Deputy Mayor, Melissa Bird, and Dr. Shemaine LaBird for their outreach. I also want to commend DHCF's work with the DC Health Benefit Exchange on transitioning residents to the new Healthy DC plan. While the rollout hasn't been flawless and challenges remain, the rapid development and implementation of this program reflects meaningful interagency coordination and a shared commitment to continuity of coverage for DC residents, and we're thankful for that. At the same time, MSDC remains concerned about persistent and growing pressures on healthcare reimbursement. When we testified last fall at the Managed Care Organization hearing, we raised concerns about payer practices that undermine fair and sustainable payment for care, including systematic downcoding of physician documentation and restrictive reimbursement policies, such as restricting reimbursed time in areas such as anesthesiology. These trends are not unique to the district. They reflect a broader national pattern of cost containment strategies that place increasing strain on physician practices and risk compromising patient access and quality of care. We urge the committee to continue robust oversight of MCOs and to ensure that both managed care and fee-for-service payment models reflect fair and appropriate reimbursement for medically necessary services. And finally, I would be remiss if I didn't echo the concerns raised by other healthcare associations regarding unified credentialing. Streamlining and standardizing credentialing processes remains an important opportunity to reduce administrative burden, improve efficiency, and allow physicians to focus more fully on patient care. MSDC and our membership stand ready to serve as a resource to the committee on these and other issues. We truly appreciate your leadership and look forward to continued collaboration to ensure that the district remains a national leader in patient care and physician practice. Thank you so much for the opportunity, and happy to answer any questions either now or later.
Thank you. Crystal Jackson.
Hi, good afternoon. Greetings, Chairperson Henderson, and to the Committee on Health. Thank you for the opportunity to testify before you once more. When we last spoke in September of 2025, myself and another doula echoed our challenging experiences navigating the doula benefit to ensure families in the district looking to have doula support through their Medicaid insurance can receive that care. There has been some progress since our last interaction. However, my picture of success is for all doulas looking to be established as Medicaid doula providers to navigate the benefit with ease. It is not sustainable for two doulas to bear the caseload of all medical beneficiaries seeking doula support. I am still calling for robust and long-lasting solutions to implementation of the DC Medicaid doula benefit. So within the support of my community, the Ward 8 Health Council and its Maternal Health Working Group, the Doula Learning and Action Collaborative was formed in October of 2024 with the same goal, increasing access to doula support for doulas and families utilizing the Medicaid benefit. The DLAC, as we're calling it, has since been recognized by DC Healthcare Finance to stand as the leading body of the DC Doula Advisory Council as part of TEMA regulations. We are excited to have this partnership and collaboration. The DLAC team, and now Doula Advisory Council, consists of 10 doulas, community groups such as First Shift Justice, CompuCare Recycling Center, Community of Hope, 3 of the 4 MCOs, Healthcare Finance, as well as DC Health and other healthcare providers. And together, we will complete a landscape analysis, establish an MCO working group to create and troubleshoot standard operating procedures for doulas, credentialing, and billing as our initial goals for 2026. So it is my understanding that Healthcare Finance believes the doula needs have been satisfied by offering support to Queen Mama Doula Services, who I represent, as well as Birthing Kind, I just want to make it abundantly clear that the work is far from done, and underscore that with community collaboration, such as the Doula Learning Action Collaborative and the Doula Advisory Council, we are just beginning the journey. In order to sustain ourselves through this journey, specifically reducing instances of maternal mortality and morbidity by mobilizing the doula workforce, I posit that we don't forget our doulas, continued transparency and collaboration with doula providers, unrestricted funding for projects supporting the doula workforce from healthcare finance as well as MCOs, and support, probably most importantly, support for families looking to find doula care through the changes in Medicaid access is what is required. Thank you.
Thank you. Holly?
Yes, thank you. Good afternoon, Chairperson Henderson and Health Committee members, and thank you for this opportunity to testify. My name is Holly Eaton. I am the Senior Attorney in the Office of the DC Long-Term Care Ombudsman. Today, I would like to address the Ombudsman Program's concern about DHCF's failure to exercise appropriate oversight of the EPD waiver program, specifically Services My Way. As you know, last year's Brown versus DC decision requires DC to make a concerted effort to regularly inform nursing home residents of their right to receive services at home and facilitate putting EPD waiver services in place. Moving more nursing home residents out of DC facilities into their homes would allow more DC residents currently residing in Maryland nursing homes to return to DC closer to their loved ones. However, there is a significant challenge for anyone currently using or interested in using Services My Way, the self-directed option for EPD waiver beneficiaries who want to hire family members, friends, or caregivers to provide their care. GT Independence is the current contractor providing the supervision, budgeting, and payroll functions necessary to run the program. Over the past few years, our office has received numerous significant complaints about GTI. One of the biggest is GTI's failure to pay all participant-directed workers, or PDWs, which is what aides in this program are called, on time. I have a client who spent 2 full years trying to straighten out the payroll for 2 of her workers. She was gaslighted by GTI throughout, told it was her fault for going over budget, which turned out not to be true. GTI just hoped she would go away. Finally, settled through the fair hearing process. It was settled through the fair hearing process, but it should never have had to go to court. The Ombudsman Office and my colleagues at other community legal services organizations see these cases on a regular basis, but these are only the ones that come to our attention. How many beneficiaries just give up because it's too much trouble? This is a serious problem for 2 reasons. First, DC law requires an award of treble damages to employees whose employers fail to pay them on time. With the Services My Way contract, the beneficiary is deemed a common law employer. So in effect, the workers would have to sue the person they are serving, often a family member, who has no control over payroll and is rebuffed when they attempt to resolve the issue with GTI. There are no consequences whatsoever for GTI staff to ignore, obfuscate, and blame the victim. Meanwhile, hardworking individuals who rely on the money they earn to pay rent, put food on the table, are left for months, even years, waiting to get paid. Second, not surprisingly, many workers quit to find work with more reliable pay. These workers are an essential component of the healthcare provider workforce needed to serve our long-term care Medicaid beneficiaries. With a shortage of licensed aides in nursing homes and home health agencies, these workers take some of the strain off an already overburdened system. Driving them away is the worst thing DC could do, especially with the added burden that implementation of the Brown decision will bring. I have a number of additional issues that I will raise in my written testimony, and thank you for this opportunity to testify.
Thank you. Fernanda?
Hi, good morning, Chairperson Henderson and members of the committee. Thank you for the opportunity to testify today. We're grateful for DHCF continued partnership and support for home visiting programs for first-time parents. We also appreciate the increased funding this fiscal year made possible by council investments. This funding has the potential to secure our Nurse Family Partnership Program and support hiring 1 additional nurse home visitor to serve 25 more first-time mothers. However, we remain concerned that the HCF does not intend to submit a state plan amendment to allow Medicaid reimbursement for nurse-led home visiting services. The SPA is a smart and efficient way to leverage Medicaid dollars, consistent with council intent and would strengthen the long-term sustainability of the NFP program in the district. We're also concerned about persistent delays in issuing the home visiting funding opportunity. Over the past 2 fiscal years, funds have been released several months into the fiscal year, creating gaps that program must absorb. As we work to expand services, we urge DHCF to align its funding timeline with the fiscal year. Our ask for the record is that DHCF submit the SPA to implement Medicare reimbursement for nurse-led home visiting services and align grant funding timelines with the fiscal year to prevent funding gaps and maximize federal dollars. We appreciate DHCF's collaboration and look forward to continuing to work together to support first-time families in the district. Thank you.
Thank you. Gabby?
Good afternoon, Councilmember Henderson, and thank you for the opportunity to testify today. My name is Gabby Salado. I'm a Student Services Coordinator at Brea Public Charter School. My job is to support families with their education needs, and many times I also support them with health and basic needs. I would like to share a short conversation I had with one of our parents. The parent said, "Good morning, Miss Gabby. I did not come to school today because my face is swollen." I asked, "Oh no, what happened?" The parent said, "My teeth hurt too much. I asked, "Have you gone to the doctor yet?" The parent said, "No, Miss Gabby, I have no money. This is too expensive for me." Then there was silence for a few seconds because we both know that dental care is too costly without health insurance. He ended up in the emergency room that night. This ER visit could have been prevented if Alliance still covered dental services. Many of the families I work with have DC Healthcare Alliance. It is a program that works and helps many families get medical care, but right now, dental and vision services are not included and families are suffering because of this. We have family who are doing their best to invest time in learning English so they can support their children with their education and secure higher paying jobs to have economic stability. But as we all know, none of this matters when the person is not healthy. Restoring dental and vision services to the DC Healthcare Alliance is a real need for many DC residents. Dental and vision they are not extras. These are a very important part of our health. DHCF not utilizing the contingency list funds is a performance issue that has delayed care for many Alliance members throughout DC. So thank you for your time and doing your part in ensuring that families have access to great medical coverage. Also, Claudia Sosa had an emergency. She cannot be here, but I can read her testimony when it comes.
Okay,
thank you.
Lisa Queen?
Good afternoon. My name is Lisa Queen. I'm here to speak about Medicaid managed care, DHCF, monitoring, and MCO accountability. At recent hearings, the council heard that DHCF relies primarily on managed care organizations, or MCOs, to monitor Medicaid providers. However, serious complaints continue to evolve around medical and dental offices that remain in the MCO networks. Investigations are delayed, and the public is not told what corrective actions are taken or whether the providers are suspended or removed. So my questions are straightforward. How many providers has DHCF suspended or removed from Medicaid in the past couple of years due to patient safety concerns? How long does it take DHCF and the MCOs to investigate a complaint once it's received? What penalties or corrective actions has DHCF issued to MCOs for failing to monitor their provider networks? And so I have a lot more questions, but I will submit those. But I wanted to make a comment on some of these providers that I've heard. Some of them I've had attempted or used some of their services. And I wanted to start with Mary Center. So I see Mary Center is flooded with speakers. But I know for myself, when I attempted to use Mary Center to get dental treatment, that I had to call approximately 5 to 6 times with people canceling. And these are the answering service or whatever service they provide to answer the phones. And attempted to make some complaints about Mary Center calling different extensions, but Mary Center did not want to take the complaints or concerns. So my concern is that a lot of these nonprofits put services there that they actually don't provide. Mary Center says that they provide endodontists, which they do not. You can look on their website, and they are not the only ones. There are other nonprofits that say that they provide certain services in order to get more funding that they actually don't provide. And I'm here to plead with these nonprofits. If you don't provide the services, please don't list them. And take the time out, even to start today, to remove those services that you do not provide. And I also wanted to make a comment about long-term services and Services My Way, which I also had a chance to use or try to use. So the long-term care at DCHF, they actually cause their own issues. They are the worst program that they have in DHCF, and they definitely contribute to their own program, to their own issues. So they should start there and to see what is going on. I actually was had a medical issue where I had to get long-term services when I acquired sepsis, and it was a absolute horror to deal with long-term services. So they need to start looking within before they get on here. Thank you. I'm going to submit the rest of my questions, but most of them are like going toward DHCF.
Okay.
And I will submit those.
Thank you. Thank you. Okay. Ms. Alato, you want to read Claudia's testimony? Okay.
Good afternoon, Councilmember Henderson. Thank you for the opportunity to testify today. My name is Claudia Sosa. I am a mother of one kind child and a student at Brea Public Charter School, where I am learning English. I have testified before about how important the DC Healthcare Alliance is to me and to our community. Today, I want to say thank you for the Alliance and the medical services it provides. The DC Healthcare Alliance helps my family and many others get the care we need. It gives us peace of mind and helps us stay healthy so we can work and study and take care of our children. I am also here to say that we need dental and vision services. Dental care is very expensive, but is essential to our health. Many families, including mine, postpone dental and vision care because we cannot afford to pay out these services out of pocket. When we have tooth pain or vision problems, it is hard to live and work with dignity. Thank you for all that you do. Please do not forget about families like mine who also live in this wonderful city. Thank you for your time.
Thank you. Thank you so much to this panel of witnesses. Ms. Eaton, we'll certainly follow up around oversight in terms of Services My Way. Just to clarify, wait, are you still here?
I'm here.
Okay. GTI is the contractor, correct?
Correct.
Okay.
GT Independence, yes.
Okay, so we'll definitely follow up on that. Ms. Jackson, if you're still here, it's refreshing to hear that things are sort of moving in the right direction from the last time that you testified in September. What would you say are still the top 2 to 3 things that still needs to happen on the part of healthcare finance?
I think it's just a matter of moving a little quicker, and as far as providing standard operating procedures for doulas to enroll for like credentialing with healthcare finance before then we move to enrolling with the different MCOs. That's still a maze for a lot of my doula counterparts who are looking to engage in the benefit. And so that's a hindrance and like barrier to access for care for the families that want doula support.
Okay. We'll definitely follow up on that. And we had planned to have a maternal health hearing specifically in March. But then I got another agency that I didn't have before that now I need to hold a hearing on. So, but that's going to happen earlier. Well, hopefully before the budget process is our plan, to sort of dig more deeply into some of these issues, but also bringing in DC Health to the conversation, because they certainly have a role as well, when it comes to certifications and otherwise, and where we are in terms of the data pieces. So, but thank you so much for being here, and we'll certainly follow up on that front.
Thank you.
Ms. Salato, I'm with you in terms of dental and vision. We all have teeth, we all have eyeballs. And I mean, like, I always talk about how I feel like, this obviously this predates all of us. When Congress made the decision to separate out dental care and vision care from the rest of your body, that was like, I think, a cardinal, I'm not going to call it a cardinal sin, but it was something that, like, it began the fragmentation of public health, even from that decision, right? Because you can get infections if you have an infection in your teeth that is not properly identified. People who are getting diseases in the eyes that are impacting the rest of their bodies, but if you don't go to an ophthalmologist, you won't ever catch it. And so that is definitely something that we can continue to push on. In terms of my advocacy with the mayor's office, is that dental and vision is not that expensive, actually, in terms of the grand scheme of coverage options. And so this is definitely something that we're going to keep pushing on. So thank you for being here. Ms. Queen, I wanted to ask you a follow-up question. And thank you for being here. I talked a little bit, well, if you're still with us, I did talk a little bit earlier about network adequacy and provider oversight, but you bring up a very interesting point here around providers listing services that they aren't actually able to provide in that time, right? Especially you talked about, a specialty care within dentistry, but it is a service that people need. But if you don't have someone who is able to do it, don't advertise that you're able to hold that. But I'm going to ask some questions of healthcare finance on Thursday about, excuse me, provider oversight. But I wonder, because you mentioned that you had some specific cases personally, did you report any of those to the licensing boards at DC Health? Because I do know one way that somebody is removed from the MCO is if there is a complaint and you lose your license from, say, the Board of Medicine. But oftentimes people they will report to healthcare finance, but they don't report to DC Health.
So yes, I'm so glad that you asked that question. So currently, I can tell you without going into specifics, a physician that I reported, and actually took 3 years for, I think the same person has been there, who is head of the medical board for physicians. And what he will do is he will wait till the term is over. It's usually a 3 to 4 year term before they have time to investigate. And then he will say that I don't have enough, I have some more questions, I don't have enough answers, and he will close the case. So I think the last one I reported was earlier this year. So I definitely would, let me just ask you really quick, is there any hearing coming up for the Department of Health?
Yes, so there is a hearing for DC Health. I don't have the date.
That's fine.
Somebody's gonna send it to me. Oh, February 18th. We also, Board of Medicine is not one of the boards that we're doing, but we're gonna do a separate hearing specifically for some of the boards. I think Board of Nursing is one that we're doing, Board of Dentistry, and a couple others. So
yes, ma'am. So let me just say this. So I'm not sure what type of connections that they have within the community or whatever, but those complaints, all of them are basically, unless it's something extremely severe, like someone's life has been lost, those complaints all get thrown out. And they say, okay, there's not sufficient information, but they don't come to you and ask you for the information. So all of the complaints about physicians and nursing, and I can go back to me complaining also about Children's Hospital, blah, blah, blah. All of those complaints got trashed. So that is what's going on. If you like more details, I can contact your office, but you need to know what's going on with that. It's extremely important. Everything is getting trashed. And so I would just say before I go leave is that if the Department of Health has some questions, they don't have enough questions for the investigation, they need to contact that person, give them an opportunity to give some more documents, interview them, or whatever they need to do. And actually, I went to someone named Lisa Anderson and made a complaint about that. She told me to upload my complaint about a physician directly to her. I haven't heard from them, but they need to reach out to people to say, okay, if you need some more docs, if you need footage, if you need whatever, and stop throwing those complaints out.
Okay, thank you. That's good feedback and super very helpful. We'll follow up with DC Health on that front. I don't have any further questions for this particular panel, but thank you so much for being here, and certainly upload your testimony for the record if you haven't had a chance to do so already. Okay, we have our final four. Rosa Cruz, Catalina Quinteros, Gibran Eubanks, and Gwen Umbach. Again, you have to accept our invitation to become a panelist. And we will bring you right on over. Okay, Rosa is with us. Rosa, why don't you go ahead and get started? Go ahead, Rosa.
Okay. Hello, council members. Thank you for the opportunity to testify today. My name is Rosa Cruz. I am mother and I have a child in pre-K. I am also a student in Brilla Public Charter School, where I have been studying for many years. I work hard to improve my English every day in class. I am very thankful for DC Healthy Care Alliance. This program helps my family get medical care when we cannot afford private insurance. Because of the alliance, we can see the doctor, get checked up, and take care of our health. The DC Healthcare Alliance gives us peace of mind. It helps us stay healthy so we can work, study, and take care of our children. This program is very important for the families like mine. I am also here to say that we need a dental and vision service. Dental care is very expensive, but it's essential to our health. Vision care is also important for the adults and children, especially for learning in school. Many families wait too long to get dental and vision care because we cannot afford to pay for this service. Thank you for all you do. Please do not forget families like mine because depend of the DC Healthcare Alliance. Thank you for your time and the opportunity to speak.
Thank you. Catalina?
Yes. Hi, good afternoon, Council Member Henderson, and thank you for this opportunity. My name is Catalina Quinteros. I am a resident of Ward 4, and I am speaking today as both a parent and a student in the Brilla community. Recently, our community experienced a very painful loss. This reminded us and how deeply family depends on agencies during the hardest moments of their lives. Too often, families are forced to navigate the systems that are difficult to understand, slow to respond, and poorly coordinated. This creates additional stress at a time when families are already facing grief, health challenges, and financial hardships. We are grateful to the staff who work hard every day to support families. At the same time, we believe these systems must improve. Families need communication, stronger coordination between agencies, and more family-centered approach. I also want to highlight the urgent need for dental and vision and healthcare service to be restored. Dental and vision care are essential to overall health. Many families in our community cannot afford this service and are forced to wait for long for care. This affects both adults and children and make it harder to work, learn, and thrive. We look forward together to strengthen the system so families feel support, respected, and not overwhelmed during critical moments. Before I finish, I want to leave this with everyone in this room. When systems work with family instead against them, healing becomes possible. And that is what our community deserves. Thank you for this opportunity.
Thank you. Mr. Eubanks.
Yes, good afternoon. First, I just want to flag quickly, council member, one of my members is Gwen Umbach. She's on the Zoom, but she says she didn't receive the pop-up to join the panel. Is there a way we might be able to just resend that to her if possible?
Yeah, we'll resend it.
Thank you, appreciate it. So yes, thank you for the opportunity to testify today. Again, my name is Jabron Eubanks. I'm the political organizer for 1199 SEIU United Healthcare Workers East. We represent healthcare workers across the healthcare continuum up and down the East Coast with thousands of healthcare workers here in the District of Columbia. And I'm here testifying today on behalf of 1199 and our members to discuss the impact of changes to Medicaid and DC Healthcare Alliance. As we face massive cuts to Medicaid with over 40,000 DC residents estimated to lose their health coverage, I want to give a perspective on what that could mean for workers and DC residents. Hospital workers at every level are understaffed and overburdened. In order for a hospital to run efficiently, every department must be fully staffed. DC is currently ranked last in the nation in ER wait times with an average wait time of 301 minutes. Two contributing factors of these extensive wait times are short staffing and uninsured residents. If DC Alliance is phased out, we will see an influx of people visiting the emergency department instead of their primary physician due to loss of coverage. Our goal should be to practice prevention by ensuring residents have affordable and accessible healthcare to avoid hospital visits because preventative healthcare saves lives. Increased medical debt is also a major concern of ours when we think about cuts to Medicaid and Alliance. We know that 1 in 5 DC residents are in medical debt, causing mental and financial strain on households. Patients with medical debt are more likely to skip or delay necessary health care, fearing more medical debt. As more residents lose their health coverage, they will be at risk to accrue medical debt for services they cannot afford. This will add to DC's overwhelming racial wealth gap because households of color in DC are twice as likely to have medical debt and 4 times more likely to be uninsured than their white neighbors. Therefore, we're requesting that DC Healthcare Alliance be fully restored, funded, and expanded. Dental and vision are crucial services that the basic health plan has not been proven to provide. We represent workers at Whitman Walker who have highlighted numerous life-saving stories from DC Alliance. Changes to premiums and specific services are causing detrimental impacts to these patients' lives. To keep DC healthy, we must ensure our residents have access to this program. Thank you.
Thank you. And finally, Gwen.
Good afternoon. My name is Gwen Umbach, and I work at Whitman Walker Clinic here in DC as a paralegal. Since 2020, I've helped DC residents apply for, renew, and use DC Medicaid and Alliance. And all client names I use today are pseudonyms. In these past 5 years, I have met hundreds of people who rely on DC Alliance for their medical care. One client, Carlos, lost his restaurant job after a leg injury. Unable to stand all day at work, he had no way to earn money to pay for medical care. Once I got him on Alliance, he was able to get surgery on his leg and go back to work. Another client, Maria, watches her grandkids and helps around the home during the week so her daughter can work. She takes diabetes medication, so her whole family's routine and her life are in danger if she cannot access her meds. The Alliance changes that started October 1st are hurting these clients. Now that Carlos is back at work, his income is too high for the new Alliance limits, so he lost his coverage. Maria is still enrolled now, but if she ever misses a renewal, she will lose her insurance forever. She is not eligible for Medicare or the basic health plan, and she could never afford diabetes meds on her own. So quite simply, if she loses DC Alliance, she will die. One of the Alliance changes that took place was cutting prescription coverage down to generics only. The Department of Healthcare Finance says that, quote, generic medications are safe and work just as well as brand name medications, end quote, ignoring that many people find one version of a drug more effective or to have fewer side effects than another. For these patients, they must now choose between taking worse medication for their needs or simply going without. In the first few weeks of 2026, I received several calls from clients I'd helped in the past asking why their Medicaid ended. The reduced income limit has hit especially hard for working Washingtonians who earn just a little too much to receive food stamps, but who are still living paycheck to paycheck. It is devastating to have to tell these people they cannot get back into Medicaid. I am especially worried about my clients who relied on Medicaid transportation for their appointments because the basic health plan doesn't offer transportation, and I'm afraid they just won't go to the doctor. My coworkers at Whitman Walker have gotten dozens more of these calls, and we had to create a special protocol for when people show up at the clinic and they have to be told in the waiting room that they no longer have insurance. As a federally qualified health center, we put as many patients as possible on our sliding scale discount and keep treating them while we eat the costs, but that is not a sustainable healthcare strategy. Many of my fellow workers at Unity and Mary Center have already been laid off in the last year. Nonprofits cannot make up for the lack of public services. This is a DC government responsibility. We've all seen the data. Preventive healthcare saves lives and saves money. An investment in DC Alliance and Medicaid is an investment in the city and an effective public health strategy. But beyond that, healthcare is a human right. The council has a responsibility to protect these constituents. So I ask you please to work on restoring DC Alliance and Medicaid. Thank you.
Thank you. Thank you so much to these panel of witnesses. This is the hard part of being at the end of the day, but all of your testimony is super and vitally important of sharing your experiences, sharing the experiences of the patients for whom you work with, and otherwise, and it gives us material of where we need to follow up with the agencies as well as with the executive overall. I don't have any questions specifically for this particular panel, but I thank you all for being here today and for participating in the process. Because again, it's vitally important to know what's happening both in the facilities, but also as folks are experiencing some of the policy changes in care here. Okay. Give me just a second. Okay, I'm going to close this out for today. So thank you to the public witnesses who presented their testimony. For those who have not submitted your written testimony or you were not able to attend today, we'll accept public testimony until Tuesday, February 10th at 5:30. You may submit written testimony on the council's hearing management system site at dccouncil.gov/hearings. The committee's next performance oversight hearing will be this Thursday, January 29th, where we will hear from Wayne Turnage in serving in his dual role as both Deputy Mayor for Health and Human Services and the Director for Healthcare Finance, as well as his respective teams. The time is 2:51 p.m. And I'm not entirely sure if I'm supposed to recess or end this hearing, but nonetheless, we'll be back for part 2, and I'm sure Cable will figure it out. With that, thanks so much, everybody. I don't have a gavel, but this hearing is done for today. Thank you.